Recording in progress. Okay. Okay. Hi, everybody. I'm Hideo Saka from Japan. I'm very honored and happy to have the chance to chair this session up front. And this is the big size 2 days webinar from WABIP. So this is the first day sessions. We'll begin at the history of the bronchoscopy at first from Dr. Taeko Shirakawa. I briefly mentioned about that her. She was born in Nagasaki City and graduated from Kurimoto University and trained in thorax clinic Heidelberg, Germany, and back to Japan. She was some years working in Semarian University, and finally she is working as a director of Shimizu Hospital North to the Tokyo area. So I think that I believe that she is a good history teller. So I'm very happy to hear from you. Okay, so Taeko, now stage is yours.
Okay. Hi, everybody. Thank you, Dr. Saka, for kind introduction. Shall I start?
Of course.
Yeah, thank you. Then,スライドショー最初からで。なんかでも表示になってる。これでいい？いいじゃん。これでいいですか？いいんじゃない？
No, not yet.
Okay, I will start.
I'm sorry to say, but not yet.
What? Me? Can you? Everybody, can you see my video? No.
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 Try it again, please.
Okay. ほら、やっぱしね、こうやって、こうやって、共有で。あ、そっか。そうじゃん。これでいいんだよね。で、こうして。Okay?
Good. Perfect.
Thank you very much. Now I start. Yes, this webinar is planned in honor of these two outstanding pioneers. As this year, 2025, is the centenary of Dr. Shigeto Ikeda, who was born in 1925. I suggested to Pin Lee to have some memorial event. Then she organized such an excellent webinar. I'm so much moved by her arrangement, and at the same time, so much honored to make an opening lecture. This is Gustav Killian, so-called father of bronchoscopy, German doctor who opened a new horizon of the medicine. In 1897, he retrieved airway foreign body using the rigid bronchoscope. This method was really a revolution because before that, the tracheotomy was necessary for this purpose. Therefore, Freiburg became a mecca of bronchoscopy. Hundreds of doctors came to his place to learn this new method. Among his students, there was a Japanese doctor, Inokichi Kubo, who opened the door of Japanese bronchology. He came back to Japan with the Killian type scopes. and performed the first bronchoscopic procedure in 1907, retrieval of airway foreign body from a 16-year-old boy, and continued this method. You see many airway foreign bodies retrieved by him. This is Chevalier Jackson, American doctor, called the father of bronchoscopic surgery. He developed Jackson-type bronchoscope with a lamp at its tip that makes a much brighter image. At the same time, he developed various accessory instruments. This is his procedure. With the instruments developed by himself, he retrieved many foreign bodies, just same as Kilian and Kubo. Furthermore, he took important role as a teacher and the organizer of the society. One of his students is Joe Ono, a Japanese doctor. After coming back to Japan, Ono also enthusiastically performed the bronchoscopic method taught by Jackson, and also contributed his energy to teaching, organizing the Japanese society, hosting the International Congress. In 1960s, Ono met Shigeto Ikeda, who would bring about revolution in bronchology. Shigeto Ikeda, born in 1925, just 100 years ago, in Tokyo. When he was a medical student, he fell ill, tuberculosis, and underwent surgery. But he decided never to give up and became a doctor to treat the patients suffering from the same disease. He began bronchography. One day, he was so eagerly doing the bronchography, suddenly he fell down due to irradiation exposure and urgently hospitalized. He was so much concentrated that he completely forgot the time. In 1962, he was invited to newly established National Cancer Center. Here with Dr. Tsuboi, using Tsuboi-type curette, he was doing the diagnosis of lung cancer under rigid bronchoscope. But with rigid scope, observation range was restricted, and under local anesthesia, the pain of the patient is great. Is there any good method to observe deeper part of bronchus that does not torture the patients? The development of a new method was urgent desire for the many doctors and pulmonologists and thoracic surgeons. In these days, many people are trying to apply the glass fiber technology for medical use. In 1962, Ikeda succeeded to apply glass fiber to the rigid scope for brighter illumination instead of a small lamp. In the same year, Ikeda developed to apply the glass fiber to extend a more powerful light source and named it rigid type bronchoscopic telescope. Then he got an idea to develop flexible bronchoscope using glass fiber also for imaging. If this method realized, it would be obvious that not only the patient's discomfort would be reduced, but also the diagnosis would become more certain. Nothing but developing this scope must be my duty. Ikeda was firmly convinced of that. it would be just a dream, considering the level of those days' scientific level. However, for a scientist, dream is source of creation. In January 1964, Ikeda asked Haruhiko Machida in Machida Endoscope Company to produce flexible bronchofiber scope. Ikeda indicated 9 requirements: 1 outer diameter less than 6 mm, image guide fiber less than 15 microgram, more than 15,000 in a bundle. "Oh my God," Machida shouted, "do I have to satisfy all these requirements?" Everything seems to be to the most difficult subject that Machida had never experienced. In fact, it was very difficult. After many series of trial and errors for more than 2 years, it was July 23rd, 1966, that Machida finally visited Ikeda with the first model. The first bronchofiberscope in the world was born. Ikeda's hands were slightly trembling with excitement. It was 3 months before the 9th World Congress of Disease of Chest in Copenhagen, Denmark. Therefore, using this scope, Ikeda took 60 mm film titled The Development of Flexible Bronchofiber Scope and flew to Copenhagen. After oral and film presentation, Ikeda took the actual scope from his pocket and showed it to the audience. "This is the bronchofiber scope that I have developed." Just at the moment, people rushed toward the stage to look at it closely. The chairman was very much embarrassed. "Dr. Ikeda, would you please go out and show it in the lobby? Many other presentations should be gone." Ikeda went out, but half of the audience followed him to the lobby with great excitement. After that, when Ikeda was walking in the Congress venue, he was frequently asked, "Are you Dr. Ikeda? Would you please show me your flexible bronchofiber scope?" But this scope still needs some development, improvement, and after 4 model, this is already go to the in the commercial market. This kind of development, and in this year, Olympus also developed a flexible bronchofiber scope. In 1968, Ikeda was invited to the United States NIH, Johns Hopkins University, and he showed the film. The bronchoscope went deeper and deeper to the bronchi, and everybody was very much astonished and excited and clap their hands and stamp their feet. In 1970, Ikeda was invited to Mayo Clinic for Mayo Lung Project. And so Ikeda's invention was widely accepted to the world. And in Japan too, Ikeda studied the mass screening of lung cancer method. And as the bronchofiber scope makes the deeper part of the observation, So the former nomenclature was no more used, so he made a new nomenclature. Ikeda also made many conference and teach to the other doctors. And he organized the Japanese Society for Bronchology, the slide is missing, and organized the World Association for Bronchology. And in 1980s, he began to develop the video scope. And in 1980s, it is the standard. The video scope became standard use. And after Ikeda, so in 1980s, new technology in the world was also developed. In early 1970s, Anderson and reported TBLB using rigid scope. In 1975, RI performed TBLB using flexible scope, enabled to reach to the peripheral part of the lung in any segment. The new dimension of therapeutic bronchoscopy was brought by Dumont with silicone stent. Not only stenting, but other therapeutic method was developed in those days, and the necessity of rigid bronchoscope had paid attention to. Those days in Japan, as the flexible bronchoscope was so widely prevailed, the rigid bronchoscopy had been almost forgotten. However, Dr. Miyazawa recognized its important role in the interventional procedure and learned from Dr. Dumont. In 1997, he organized a congress inviting the interventional bronchoscopists, Dumont, Becker, Bolliger. Other therapeutic procedure like PDT and EWS was introduced in this period. WAB also recognized the importance of interventional pulmonology and changed its name to WABIP in 2010. As a remarkable revolution in 1990s, I would like to mention EBUS, end bronchial ultrasound. Although the application of ultrasound to the airway had been investigated around 1990, these studies were interrupted. It was Heinrich Becker who really began to cultivate this new field. His motivation was that to extend the bronchoscopist's view beyond the surface of the airway. So at first, using radial type ultrasound, he developed the probe and succeeded to obtain the 360-degree view around the central airway and its surrounding structure. This method was really useful for the evaluation of the tumor invasion. However, the procedure is a little bit complicated and the interpretation is not so easy to get the popularity. Then the radial type ultrasound changed its usage to the peripheral lung lesion. This is so useful for the identification of the localization of the tumor. Soon, with a guide sheath, this is established as EBUS GS method by Kurimoto and became as a gold standard. TBNA was firstly introduced by Koppen-1 in 1978, but because of the necessity of simultaneous observation, in late 1990s, Becker began to develop the ultrasound scope for TBNA using the radial type ultrasound with Olympus. From 2002, they shifted to convex type ultrasound for this purpose and realized this type scope in 2004. Using this type scope, The needle is clearly seen during the procedure. That made remarkable improvement for the sampling. Yasufuku, this article in 2004, is regarded to be the landmark work. Talking about development of scopes, about ultrathin bronchoscope. This has been used since the early 1980s. It has become popular since the release of 2.8 millimeter Fiberoptic bronchoscope in 1999, and continuously being improved and are currently more useful than previously. Combining other devices such as EBUS and VBM, or adding biopsy techniques such as TBNA and cryobiopsy to forceps biopsy enhance the diagnostic yield. Single-use bronchoscope has been developed since 2009. Not only avoiding contamination, it has several advantages and will be used more frequently in the future. Several navigation systems developed after 2000s, like VBN and electromagnetic navigation. This can provide the precise targeting of peripheral pulmonary nodules. Those methods assist the diagnostic procedure of peripheral lung lesion. Now we can combine these modalities. For sampling, cryobiopsy is much superior to obtain larger, not damaged material than conventional forceps. Currently, there are 3 platforms available for robotic-assisted bronchoscopy. These subjects are important. But I cannot mention now because of the time limitation. Bronchoscopy started in Germany and developed United States and had revolution in Japan. But nowadays, the bronchoscopists all over the world are enthusiastically performing their activities. In early stage of my career, women bronchoscopists are minorities. However, look at now. The president of WABIP is a woman, Pindi, and the Strong Society, WIAP, was organized 10 years ago. Strong woman, my younger sisters. I'm very much proud of you. So everybody, bronchoscopists in the world, young and old, men and women, holding Ikeda's motto, never give up, let's go together for further development of bronchology, not only for the patients we are facing now, but also for the patients we do not meet yet, but waiting for us in future. Thank you very much.
Thank you, Dr. Shirakawa. I really enjoy your talk this time. Now it's the time to proceed to the next sessions. Thanks again. Okay?
Okay, thank you. How can I do that?
Thank you, Dr. Saka and Dr. Shirakawa. Very, very insightful, especially learning a little bit more of the history of WEIP. And right now we are preparing the first session from the experts of peripheral bronchoscopy. chairs of whom are Professor Stefano Gasparini, Professor Chih Yen from Taiwan, and Professor Naofumi Shinagawa from Japan.
Okay, can we start? Okay, first of all, I would like to thank and congratulate with the WABIP because this is maybe the first webinar that it's similar to a congress because it's a 2-day webinar. So it's a great opportunity for people to learn and to from expert and to talk about a lot of different procedure. It's a great pleasure for me to chair this session together with Naofumi Shinagawa and together with Dr. Tuchin Yen from Taiwan. I don't see him. I don't know if he's present. Yes, there is the connection, but I don't see him. However, don't lose time. We have to talk about different technology, and you know that peripheral nodule is one of the most important challenge for interventional pulmonology in the recent year. Now, Fumi, do you want to talk or to say something?
Yes, thank you. I'm honored to be chairing this session. I hope it will be a great success. So please start the first presentation.
Okay, so the first presentation is from Noriaki Kurimoto that I see here. Thank you from participate and for coming from Japan. And the title is Airway Mapping, Radial EBUS and Fluoroscopic Lung Biopsy. Please, Noriaki.
Thank you, Dr. Gasparini. Can I show my presentation? Could you watch?
Yes.
Okay. Could you watch my presentation? I will start. Thank you for giving me chance to present my presentation. My presentation title is Airway Mapping, Radial EBUS, Fluoroscopic Lung Biopsy. This is my COI. There is a quality of bronchoscopic procedure. The quality is to provide high diagnosis yields, to be safe procedure for the patient, to be easy for the patient, and so on. The quality of bronchoscopic procedure is unstable. Every procedure is not the same, but we try to do the same procedure for every patient. We should make up our own standardized ideal bronchoscopic procedure. Performing every procedure, we should devise our own ideal bronchoscopic procedure, going up to the head. In 2004, I reported EBUS GS for the peripheral regions. So we usually use 4 mm bronchoscope, 2 mm guide sys, 1.4 mm ultrasonic probe. So I usually checking the internal echo of the peripheral region. So the good area is around here. This is a probe. It's about 5 to 8 mm far from the probe. This area is good for the evaluation. So this is, you can see the small lines. regular lines. So we usually call this image is a homogeneous type. So this one is lung region, lung tumor, is a lung cancer. Is you can see around here is a little thickened lines and irregular lines. So I call this region is heterogeneous internal echo. It looks like a malignancy. This is a homogeneous region. That is a pneumonia. Like this one is a benign region. So I think there are 5 steps of EBUS GS. I'd like to explain these 5 steps. The first step, bronchial branch tracing. Bronchial branch tracing, I would like to explain 2 points. The first point is the 5 steps of the bronchial branch tracing, and second point is the 3-dimensional bronchial tree. So there are 5 steps of the procedure of bronchial branch tracing. The first step, reverse or rotate CT images. We do not use the normal CT images. Reverse or rotate. So when the region located in the middle lobe, lingular segment, or lower lobe, bronchus advance from the head to the foot, like this one. So you know CT image direction from the foot to the head. That be opposite direction. So we should reverse CT images right to left, left to right. So we can see from the head to the foot on the CT images. When the region located right upper lobe or left superior segment, bronchus advance from the foot to the head. CT image direction from the foot to the head, the same direction. So we should not reverse, just rotate the CT images. So when the region located in the right upper lobe, we rotate CT images counterclockwise 90 degrees. Left superior segment, we rotate CT images clockwise 90 degrees. Why should we rotate? Because we inserted the bronchoscope into the trachea and going to the carina. When the region located right upper lobe, we rotate bronchoscope clockwise 90 degrees and going to the right main bronchus, right upper lobe bronchus. So the target is on the CT images. So we should opposite direction, the CT images, we should rotate counterclockwise 90 degrees. That is the reason. So we should rotate the CT images. Second step, differentiate vertical or horizontal branch. Vertical branch is going up to the head or going down to the foot, like this one. So right lung that we call the B1, B7, B8B, B9B, B10B, or B10C. I differentiate vertical branch. Horizontal branch. So for example, this is the right upper lobe. So we are going to here, the vertical branch B1 is going up to the head. So B2 or B3 is going to lateral or anterior and posterior. This is a horizontal branch. Horizontal branch is located the mid part of the lung, like this one. Right lung in the, for example, B2, B3, B4, B5, B6, B8A, B9A, B10A. So the central area is we call the horizontal branch. The third step, the vertical branch is not so difficult. So first step, second step, we can finish the vertical branch. The third step is but horizontal branch. We are going to third step, fourth step, fifth step. So we are going to third step. So where is the patient head? Determine the position of the patient head. So when the region located middle lobe, lingular segment, or the lower lobe, so we flipped the CT images already. So the patient head is in front of the screen of the CT images, close to us. So when the region located right upper lobe or left superior segment, that we do not flip, just rotate. So the patient head is beyond the CT screen. I'd like to check, confirm the location of the patient head. The fourth step, fifth step is the almost same time I do. Fourth step is determine the longitudinal axis of the most proximal horizontal branch. The most proximal horizontal branch is, for example, right middle lobe bronchus. So I reverse the CT images here. This is right middle lobe bronchus. So right middle lobe bronchus is the most proximal horizontal branch. The most proximal means, please imagine from the head to going into the trachea. Trachea is a vertical. Right main bronchus vertical. Right intermediate trunk is a vertical branch going to foot. At the entrance of the right middle lobe bronchus is a curved, almost about 90 degrees going to anterior. So the right middle lobe bronchus is most proximal horizontal branch. We would like to start at this point. So we determine the longitudinal axis and place my point of view at the proximal site of the right middle lobe bronchus. We would like to looking this way. So this is the right middle lobe bronchus. Is for example, is looking this way. So this is my handwriting, bronchial branch tracing, looking this way. So please bend this line and putting this site is close to us, like this one. So this right middle lobe bronchus is correspond to here. You are looking this way, like this one. Pull this site close to us. The patient head is close to us. This site is a cranial. This site is a caudal. We are going to here, right and left branch, right and left branch. We draw right and left. If the region bronchus is going to superior inferior, so the superior inferior, because this site is a cranial. So three-dimensional bronchial tree. So we do like this one. Teaching young doctors, I usually use this one. Looking this way, right middle lobe bronchus. Bend at this line. Pull this side close to us. Cranial, caudal. Right and left. Up and down. Right and left. Up and down. This is superior branch, inferior branch. And the right and left. Right and left. Oblique, superior lateral, inferior medial, superior lateral, inferior medial. So I recommend practice the bronchial branch tracing every day. That'd be better for learning. So the second step is advance the scope, more periphery. Please push and push. The third step, guide the probe to the region. So this is my chart is we check using an EBUS at first within existent two invisible. Invisible case, seek the bronchus under fluoroscopy. Adjacent case, we use the EBUS images. I would like to explain the case presentation. The fourth step, confirm the location of the tip of the guide cyst. This is very important. So I inserted the region, here's the region, the scanning by the transducer, we can get the target. After that, scanning and putting back the probe into the cyst. 100% transducer is covered, the guide cyst. The EBUS image is getting dark. So we can confirm that this phenomenon. We can confirm the location of the tip of the cyst in the region. The fifth step, get the specimens. So on the fluoroscopy, we check the tip of the transducer. We marked the adhesive tape on the monitor of the fluoroscopy. So inserted the forceps and putting back and the cyst and the forceps and pushing the target. We'd like to get this site marked area by the adhesive tape. So, but the adjacent case is very difficult. Sometimes we do change to, I would like to change to other adjacent to the invisible, but still adjacent to, we are going to the pinpoint biopsy. Pinpoint biopsy is up and down, making up and down by the bronchoscope close to the region. So that we take from the lateral side of the wall and the region. This is pinpoint biopsy. So this is a chart. I usually use bronchial branch tracing. That'll be navigation. That'll be okay. So we check the EBUS images so that we are getting a tissue. This is my chart. So this is my last slide. So the diagnostic yield, we'd like to 100% the top of the mountains. So now we usually use the EBUS GS and the ultrathin bronchoscope and the pinpoint biopsy and other procedures. Thank you very much for attention.
Thank you very much, Noriaki. Wonderful presentation. You underline how is important to know the anatomy and what I call mental navigation. Before performing the procedure, you have to know very well and to study very well the CT scan and the location of the lesion in relationship with the bronchial tree. And this is very, very important step. I think that we can do the question and answer at the end of this session. And so I invite the next speaker, that is Dr. Yuji Matsumoto from Japan. Yuji Matsumoto, please can open your camera. You will speak about tips and tricks of driving the ultrathin bronchoscope.
Oh, sorry, wait a minute. My camera doesn't work.
Okay, but you can share your screen and
Okay.
so we can visualize your presentation.
Wait a minute, sorry. Sorry, as I rushed to come back to my hospital, so please wait a minute. Okay. Do you see my presentation slide?
Not
No.
yet.
Not yet. Oh,
Yes, it's okay.
wait a minute. Oh, sorry for inconvenience. Do you see my slide?
Not yet.
No, yet.
Yes, yes.
Okay. I'm sorry for you waiting for me. And my name is Yuji Matsumoto from the National Cancer Center Hospital in Tokyo. It is a great honor to have this valuable opportunity to present today. So my presentation title today is Tips and Tricks of Driving the Ultrathin Bronchoscope. This is my disclosures. And first, let me briefly introduce our hospital. It is a cancer specialized center located in the heart of Tokyo. And it is also the place where Dr. Ikeda developed the very first flexible bronchoscope. When we look back at reports on the early prototypes, their outer diameter was about 4 to 5 millimeters, equipped with a channel just large enough to allow the insertion of small devices. This was more than 50 years ago, yet even then the concept of an ultra-thin scope already existed, with the descriptions of a 2.5 millimeter scope. However, that scope had no working channel at the time and was designed mainly for mass screening purposes. Since then, development has advanced, and today a wide variety of bronchoscopes are available on the market. However, peripheral pulmonary regions are located in areas that cannot be directly visualized by bronchoscopes, and therefore, regardless of which scope we use, the key to improving diagnostic accuracy lies in the effective combination of adjunctive technologies. In the past, lesion confirmation relied solely on fluoroscopy. However, this approach alone was insufficient in terms of diagnostic accuracy. The reason is simple. Fluoroscopy provides only two-dimensional positional information, making it difficult to assess three-dimensional alignment, especially depth. On the other hand, over the past 2 decades, the introduction of Radial EBUS has made it possible to confirm whether the bronchoscope has reached the region by inserting the probe into the bronchus. EBUS is a low-end miniature probe that uses ultrasound to visualize the presence of a target region from the bronchial position where it is inserted. On the other hand, the overall outcome of the procedure is greatly influenced by the choice of scope. As I will explain later, this is a trade-off between navigability and the sampling capability, determined primarily by the outer diameter and the channel size. First, therapeutic bronchoscopes with the large working channels allows the insertion of a wide range of devices. However, because of their large outer diameter, they have poor navigability, making it unrealistic to approach peripheral lung lesions with the scope alone. The standard reference for channel size is 2.0 millimeters. When the channel size is the same, a thinner outer diameter is preferable, and this is where thin bronchoscopes come into play. Also, the range of devices that can be inserted is narrower compared with therapeutic bronchoscopes. The essential devices can still be used. This makes it a well-balanced scope. This slide shows an approach with a thin bronchoscope to a nodule in the left upper lobe with a negative bronchus sign. Even with a 4 millimeter outer diameter, it can be advanced fairly deep into the peripheral airways. In this case, the patient has stage 4 disease with abdominal lymph node metastasis, but cry biopsy confirmed an EGFR mutated adenocarcinoma. And next, I will move on to the main topic of this lecture, the Ultrathin bronchoscope. In the previous generation, the channel diameter, the model name is XP, the channel diameter was only 1.2 millimeters, so too narrow to be used with Radial EBUS. But in the current model, MP, the channel size has been increased to 1.7 millimeters, making such combination possible. From here on, I will focus my talk on this scope. As you may know, a series of studies on the diagnostic performance of this ultrathin bronchoscope for peripheral pulmonary regions has been reported by the group in Nagoya by Dr. Oki. First, the diagnostic yield of bronchoscopy combined with radial EBUS has remained in the 70% range, which serves as a practical benchmark. The most important factor influencing diagnostic success or failure is the presence of a bronchus sign. The bronchus sign refers to the identification on CT of a bronchus directly leading to the region, although its precise definition varies across studies. As shown in this slide from our center, we use our own classification and have reported its correlation with diagnostic yield. In any case, it influences REBUS findings and ultimately affects the choice of biopsy method. In cases with a negative bronchus sign, the scope often reaches only the region margin, making forceps, which can obtain samples only from the front, insufficient. Therefore, it is more reasonable to attempt transbronchial needle aspiration. And for this purpose, now peripheral periview flex needle can also be inserted into the MP scope. So let me show you an actual case. This was a nodule adjacent to a blur in the light upper lobe, approached with MP scope. The bronchus sign was negative, so the pathway was determined based on the course of the pulmonary artery branches. The target region is located at the light segment 1B. This is virtual bronchoscopy that we refer to in this case. It shows the tortuous bronchial root arising from the light B1B. The corresponding virtual fluoroscopic image is also presented here. When placed side by side with the actual bronchoscopic image, it looks as shown in the slide. With the MP scope, it is often possible to advance into such thin and tortuous bronchi, as demonstrated earlier. The related bronchus is light B1B, small 1 beta YXX. At this point, we switch to fluoroscopic guidance. Because the ultrathin bronchoscope has a low rigidity and tends to be bent easily, there is a risk of slipping back into the intermediate bronchus, so caution is required. So now we advance the REBUS probe and scanning, and REBUS adjacent to image was obtained. And we check carefully whether the scope can be advanced any closer. And after that, we switch the fluoroscopic view from anterior posterior to light anterior oblique view. This view provides a clear understanding of the region's spatial relationship. With transbronchial needle aspiration in mind, we determine the puncture site. And carefully insert the aspiration needle, the peripheral flex needle. and then rechecks the positional relationship and RL view as well as AP view. Because behind this region there is a bulla, so we carefully determine the puncture site. So finally, the pushing the needle at the cyst, we feel the resistance by the lesion. And finally decided it's the puncture site we puncture. After that, negative pressure is then applied and the needle is gently agitated while slightly changing the puncture angle. Just same as the EBUS TBNF. Upon reinserting the Radial EBUS, the finding has changed to within the region, indicating that a route into the region has been established. So forceps biopsy then is then added, and the procedure is completed. Because the specimens obtained by aspiration needle and forceps differ in nature, so they work in a complementary manner for diagnosis. I have shown examples of sampling with the MP scope, but since the bronchoscope itself can advance far into the periphery, I believe you can appreciate the importance of more precise navigation. At our institution, we utilize a general purpose workstation to create virtual bronchoscopic images from HLCT images. Even more importantly, with the use of this system or other systems, it is also possible to generate virtual fluoroscopic images. This makes it easier to anticipate the optimal fluoroscopic view to account for both directional and distance deviations. Furthermore, the introduction of cryobiopsy represents an innovative advance in sampling techniques. We have explored the application of cryobiopsy for peripheral regions and have reported its efficacies. And with the introduction of thinnest single-use cryoprobes, the 1.1 millimeter one can now be used even with the MP scope. In a feasibility study conducted by the group in Nagoya, it was demonstrated that a certain proportion of cases could be diagnosed only by cryobiopsy. So now, taking into account the use of cryobiopsy, let me present another case. The target region is a part solid nodule in the left upper lobe. The related bronchus is left B1 plus 2C. This slide also shows the virtual bronchoscopy as well as virtual fluoroscopic images. No, sorry. I forgot to cut the voice. But let me show you the case. And MP scope is very flexible, so low rigidity. So the scope is usually maneuvered by the right hand. And straightened the bronchoscope itself is very important. And the thinner working channel makes it relatively more difficult to suction well. So first, suction the airway lumen enough, and after that we check the bronchial route along with navigation route. And now you can see left B1 plus 2C on the left lower corner. And carefully insert the bronchoscope into the lumen. But usually the view range is narrow and cannot be visualized well. In that case, we usually use nasal catheter to set into the working channel and low injection of oxygen to expand the airway lumen. And then check the airway lumen more carefully to the periphery and advance the MP scope to the correct way. This is a very important point. And then switch to X-ray fluoroscopy. You can see the very fine shadow of the X-ray of the region, but the EBUS shows invisible. So next we switch the X-ray image to the anterior oblique view, and then rotate the bronchoscope to the precise location, precise rotation. And check widely while rotating widely to the clockwise way, because this region is located to the relatively anterior position. So now you can see the EBUS adjacent to mixed result sign. And carefully check the AP view, another anterior oblique view as well as AP view, and determine the biopsy site. Now the EBUS adjacent to image are getting stable, so we should switch to 1.1 millimeter cryoprobe, and then using with freezing with 6 to 8 seconds, we perform cryobiopsy using the CNS 1.1 millimeter cryoprobe, and we usually perform a two-scope technique to hemostasis when performing cryobiopsy for peripheral region, especially for the ground glass nodules. And the assistant already changed to the therapeutic bronchoscope to the light source. And then immediately after freezing and Primvax cryoprobe as well as along with the bronchoscope, the therapeutic scope wedged into the biopsy site and can control the bleeding. And the final pathology shows adenocarcinoma with the papillary growth pattern. This is my last slide. Improving the diagnostic yield in peripheral pulmonary regions requires a strategic combination of multiple modalities. The introduction of an ultra-thin bronchoscope, especially the MP1, has enabled us to maximize their diagnostic potential. Given their limitations in device compatibility, unique shaft flexibility, and reduced action power, appropriate technique adaptation is essential. Thank you for your kind attention.
Thank you very much, Dr. Matsumoto. Wonderful presentation. I just underlined two points that you showed in your wonderful cases. The first one is the use of fluoroscopy also to guide your bronchoscope. I noted that especially in the last case, you lost the bronchoscopic view and you used the fluoroscopy as a guidance system to move your bronchoscope, and this is a trick very useful. And but we can discuss this point better during question and answer at the end of the session. So now it's a great pleasure that I introduce Professor David Fielding from Australia. And hi, David, welcome and thank you to be here. And we will see in his presentation some critical point of the technology of navigation bronchoscopy. Please, David, you have 15 minutes and you can start and share your screen.
Thank you, Stefano. Can you guys hear me okay?
Yes, we hear you.
Okay, I'm just trying to... I'll just put that one down. Can you see my presentation there now?
Yes, perfectly now.
Okay, I'll start. Thank you so much, and Stefano, and also Ping and Michael for organising this wonderful presentation, a wonderful session. Just a brief disclosure slide. I have had support for study purposes from Intuitive Surgical. Just in my talk, I draw everybody's attention to these two wonderful papers by Doctors Fernandez Busey and Prado, from which I've taken a lot of the illustrations for this talk. The key features of the three systems are as summarized on this table. The main difference of the ion system from the other two systems is that it uses so-called shape sensing, whereas the position and navigation is the feedback for that comes from augmented electromagnetic navigation. And also with the Galaxy system, there is an augmented fluoroscopy component. All of them have extreme articulation possibility at the tip of the scope, and the tip of the catheter ranges between 3.5 and 4.2 millimeters across the three systems, and the working channel diameters are either 2 or 2.1 millimeters. I'll talk about tool and lesion conformation at the end of the talk. The three catheters are, as you see here, the Galaxy and Monarch systems are more kind of bronchoscope-like, and in fact the Galaxy system is a disposable bronchoscope. These systems allow vision to occur at the time of sampling, whereas the ion system is a catheter from which the optic and the light source are removed and into which the forceps and needles are placed. So it's kind of like a bronchoscope in reverse. It's essentially a channel. It's essentially a drivable channel. The three controllers are, as you see here, the ion system has a more sort of conventional computer sort of software interface, whereas the others are more sort of game-like. And this is a key point of the difference between the systems. So this is at the moment when sampling is taking place, there is the ability in a kind of a bronchoscopy-like moment to place needles and forceps into the targets with all of the various feedback happening at the time. Whereas with the ion system, it's not like that. You have to take the optic out and then move to place needles or mini probes, etc. So you can see the operator in the right picture. That's where the blue glove is. That's where the forcep is being put in at that moment. But you see the green panel, the top panel demonstrating the green shape-sensed catheter. It is displayed real time. So the tip and the position relative to the green target, the green ball target, is visible at all times. So even though you can't see the target, you know where that tip is, and in particular where it is with respect to the target. Just a couple more words about the way that the system or the Galaxy system work. It's the newest of the three systems. It employs a X-ray fluoroscopy, and first of all, that is used to provide augmented fluoroscopy, a little bit like what Yuji was just showing with his system, which is generated by the pre-procedure CT. But here you can see that just with conventional X-ray, the little blue target can be displayed as the proceduralist is driving towards it. And then secondly, the so-called tool in lesion technology or tilt technology can then additionally be used for further localization of the scope and needles directly into the target lesion. And so this is unique to this system. And these images are generated by 2D fluoroscopy with only a relatively small arc of spin of that fluoroscope. A lot has happened in the 5 or so years of clinical practice of robotic procedures. And as I mentioned, there's a lot of review papers, and this is a table from Fernandez-Bussi's summary, which shows the systems, the reports from the systems, where we've got 22 papers with ion, 9 papers from Monarch, and 1 paper from Galaxy, which was published by Taj Sagai and colleagues there in 2023. I think a lot of the difference that's happening with these studies is the small size of the tumors. So if you look down that middle column, mean diameter in millimeters, it sort of typically ranges around the sort of 15, maybe 20 millimeters in size on average. But there's quite a few papers averaging around the 15 millimeter mark. And this is a big difference. And it's also, there tends to be quite uniform results sort of in the sort of low to mid 80% across the board in terms of diagnostic yield. Now, I think someone else is talking about the nature of what diagnostic yield actually is either later tonight or tomorrow. But nonetheless, there's a kind of relative uniformity of what's happening there. And further to that, there are these 3 meta-analyses that have now been published. And I draw your attention to these, and they're extremely well-written papers. There's Piarali's paper from 24, Lee's paper from 25, and Zhang's paper from 24. and large numbers of patients, between 700 and 2,500 nodules, have been reported in these studies. The lesion size across the studies, you couldn't do a median, but they ranged in the studies between 6 and 25 millimeters in size. And you can see there the pooled diagnostic yields are between sort of 80 and 87%. In the Lee paper, they made a distinction of those papers that actually could be determined to have used a strict diagnostic criteria, in particular looking at strict interpretation of benign biopsy reporting, and that the yield there was 78%. And in general, yield for malignancy is always a little bit higher for the reasons of benign biopsies being a bit harder to define. Just a couple of notes from these meta-analyses. Overall, as I've mentioned, the results are significantly improved compared to what's happened historically. This is going back into the 70s when conventional transbronchial biopsy was all we had. And then we had electromagnetic navigation, which got us to about 70%. And now with these studies, they're consistently around the 80 to 85% mark. As I've mentioned, there's this the phenomenon that we need to be wary of the diagnostic criteria, and also that this in turn is impacted by the prevalence of malignancy in the series, just as they have presented to these doctors. So if the prevalence of malignancy is low, then on average, the diagnostic yield overall is about 67%, whereas studies with a prevalence of more than 60% of malignant cases have the diagnostic yields of 83% as a group. So this is a key aspect of our understanding of how the literature is reported. In terms of what about the two systems, in general, there's not a lot to pick between them. And in fact, Pirali showed no difference from a statistical perspective. With the shape sensing, it was 84% compared to 77%. And with Lee, the pooled sensitivity did show a statistical difference between the 80% for Monarch and 93% for Galaxy. But I guess it's early days, and many more studies have been presented by those earlier papers. But in general, the results overall are very good. I'll mention briefly about cone beam CT in a moment, but these meta-analyses couldn't really demonstrate an additional benefit of that. And it's probably due to the limited number of studies. This is also very important data that we're tending to biopsy lesions less than 20 millimeters now with robotic systems, and there was a difference if it was greater than or less than 20 millimeters, going from 86 to 78%. But even still, 78% is good when you're talking about lesions on average being less than 20 millimeters. And similarly, Zhang did not report a statistical difference, but there was that sort of 5 to 10% drop going from more to less than 20 millimeters. As expected, there was an impact of bronchoscopy, but in general, in robotics, we haven't tended to worry about the presence or absence of bronchoscopy. And there was an interesting result that studies where there were less than or more than 100 biopsies reported. It actually was better in the cases with less than 100 biopsies, but it just so happened that this was confounded by patients with somewhat more difficult lesions in that there was a lot more invisible EBUS cases, and that there was a lower malignancy prevalence in those cases with more than 100 biopsies. So I'm not sure how to interpret that really. So just to briefly mention, what I've described so far is just robotics, but adding 3D imaging is very much a part of the equation now. And as I've mentioned, the Galaxy has this inbuilt, whereas CEOS Spin, you can add a sort of a mobile cone beam CT, be it Siemens or GE, and this can be directly integrated into the target position adjustment, as I'll show you in a minute. And there's another system called Lung Vision, which has been studied with Monarch. And I draw everybody's attention to Ravi Kumar's paper from Diagnostics in 2023. It's really excellent summary of this point. And I guess what we're saying is that the planning can only get you so far, and it's good, but it's not perfect. And we have CT to body divergence, especially in the lower lobes, and that these are very small lesions indeed. Now, Mr. Chairman, how much longer have I got?
Stefano. Dr. Fielder is asking how much longer David has.
Yes, you have finished, David.
Would you have I used my time up, Stefano?
Oh, you can have 1 or 2 minutes more.
Okay. So yeah, so thank you. So just briefly to mention the way that CEOS Spin, which is the Siemens system, can be used to directly confirm the actual position based off a cone beam CT, to then allow the previous target to be moved to the new position and for biopsies to continue. And just to say that augmented fluoroscopy in its conventional form is being applied with a lot of robotic systems now, and that the lung vision system that has been studied with the Monarch system is also another way that this computational and AI sort of tweaking of the two-dimensional images can give this kind of three-dimensional assistance. So I'll stop there. I just those are my slides for my case. But I'll just finish there and say that in general, robotics has improved the yield compared to historic data, especially for lesions less than 2 centimeters. In general, we're not talking about significant differences in comparative studies between the 3 devices, that ongoing improvements are likely to follow with 3D imaging, and that, as always, we have to look at all of the health economic aspects of this, because these are costly devices, and this is the challenge for us in our clinical research work. So thank you very much for your attention.
Thank you very much, David. A wonderful lecture. You showed us all the differences and between the 3 robotic systems. I asked to Naofumi if you want to continue to
Yes,
share.
yes. Yeah, I will do that. Thank you, Dr. Babbitt. So now we will now begin with the challenging case session. I'm Naofumi Shinagawa from KKR Sapporo Medical Center, Japan. After presenting the region, I will ask some doctors to brief comments on the optimal approach. So I will present one case, and Dr. Matsumoto present two cases. So first case, Stefano, can you comment after my presentation, right? Okay.
Okay.
Yeah. So let's start. Oh, can you see?
Yes.
Yeah. Okay. Let's start. So this is my COI. So first case is a female patient. She had a past history of advanced bladder cancer 7 years ago, treated with a chemo and surgical resection. So abnormal chest.
You should put in presentation mode, because we are seeing also the following slide. We are seeing
can't you
two
see my
slides.
slide?
I see two slides.
Okay. Okay. Now?
Perfect.
Yeah, yeah. So chest X-ray revealed a small nodule shadow with a cavitation in the right upper lung. And CT demonstrated a cavitated nodule located subplurally in right S2, and PET showed intense uptake in the same region. So this is a synthesized CT bronchus. Yeah. Here. Running near the cranial margin of the region, but it is unclear whether it reaches the region. Similarly, bronchus can also be seen on the caudal here. But again, it is uncertain what it is the region. Then CT bronchus sign is considered negative. So how would you approach this case, Dr. Gasparini? Please comment.
Oh, I think that in most of the institution, this case would be approached by percutaneous CT guided.
Ah, yeah.
Because it's very, very, very close to the thoracic wall. So I think that in the world, about 80% of people would approach this nodule using percutaneous approach.
Yeah. Okay. Thank you. Thank you so much. So before Bronchoscopy, which reveals that the cranial root is highly complex. First, directed cranially, and then turning caudally. Yep. So the other route conversely required abrupt cranial turn at the end and was also found to be technically challenging. Since advancement of bronchoscope into the periphery relay on the pushing maneuver, the ideal route is considered to be a straight bronchus, extending direct from the hilum. In this case, either the cranial or caudal route was difficult to to approach with a 4 millimeter thin bronchoscope. So we elected to use a also because the tip of the bronchoscope could not be angled sharply enough towards the lesion. So therefore, a cranial approach was attempted. However, the entrance of B2A was narrow, and even the ultrathin bronchoscope could not be advanced further inside. So also the bronchoscope could be then we decided to use a technique called BDBD, balloon dilation for our bronchoscope dilator, in which the target bronchus is dilated with a small balloon to allow the bronchoscope to be advanced further into the periphery. The left image shows the balloon dilation of the bronchus, which enables insertion of the bronchoscope into the periphery portion of B2A. From this point, the bronchoscope angle was adjusted. Under X-ray fluoroscopic guidance, the chip could be advanced to be positioned very close to the region. But unfortunately, Radial EBUS could not be visualized the region from any route. Brush cytology was performed from the cranial route, but no diagnostic specimen was obtained. So surgical resection was eventually performed, revealing inflammatory findings suggestive of infection, though the causative organism could not be identified. So this is a summary. We should carefully consider in advance whether insertion is feasible, but grasping the bronchoscopic approach route in 3 dimensions. An easily accessible route is one that allows the most linear approach possible from the hilum to the region. BDBD may serve as a promising approach to enhance access to peripheral pulmonary region. So thank you.
Thank you very much, Naofumi.
Yeah.
Wonderful case that demonstrate that not all the nodules are lung cancer, and that PET scan cannot be accepted definitively to demonstrate that lesion is PET positive and cancer. PET can provide false positive for inflammatory lesion. Thank you very much for this case.
Yeah, so please, Dr. Matsumoto, can you start next case? So Dr. Professor David Fielding, are you here? Are you still here?
Yes, I am. Yep.
Okay, so please comment shortly after presentation.
Okay.
Yeah. So Dr. Matsumoto, please start.
Sorry, do you see my slide?
Yes,
Yeah.
please.
Okay. So, hello again, and I will show you another 2 cases of challenging problems and regret. And case 2 is a 60-year-old male. Smoking history is known, and present illness was detected on routine chest X-ray screening, and past history only appendicitis. And chest radiograph shows a very small nodule in the right middle lung field. And the CT shows around 8 millimeter sized nodule in his right segment 4. I will show you the HOCT images, and the target region is located at the right segment 4A, and the bronchus sign is negative. FDG PET shows a high uptake at the region. So again, how would you approach this case? Shall I keep on?
I would try with the transbronchial approach.
Okay, thank you. Okay, I will keep on my presentation, and next I will show you the virtual bronchoscopy image. As I told you, the rated bronchus is light B4A, and colorated virtual fluoroscopic image is shown the same. Again, I will show you the virtual bronchoscopy image, and we approached use for this case using a P-scope, thin bronchoscope, and the tip of the bronchoscope was stopped at this point. Here we switch to fluoroscopic guidance and advanced EBUS probe, and you can see that the scope tip has stopped much again. First, the tip of the bronchoscope location was very far from the regions around here, but along with the EBUS probe guidance, it can be inserted into more periphery. And what is important here is that even when the scope alone lacks sufficient stiffness to be advanced distally, using EBUS or as devices as a guide often provides a clear direction of force. This makes it possible, as in this case, to advance further towards the region. As the tip of the scope approaches the region, the number of remaining branch points decreases, and reaching the target becomes more stable and achievable. Since EBUS was confirmed and adjacent to the finding, we rotated and checked another fluoroscopic angle, but normal close to the region. So we switched to the cryo of this case. And as I showed in my earlier presentation, we have achieved introduced cryobiopsy for peripheral regions and have reported its efficacy. In particular, circumferential cryobiopsy has proven to be especially variable in cases where EBUS adjacent to the region. And we have reported that for peripheral regions measuring 30 millimeter or less, the 1.7 millimeter cryo probe alone, single-use cryo probe alone can achieve a remarkably high diagnostic yield, 94%. And the yield was reached plateau after 3 or more biopsy. But also single-use cryo probes have become thinner. The stiffness is almost same. Therefore, if the bronchoscope bends at a sharp angle, we usually shape like this spring-like. And returning to the previous case, although the first biopsy did not yield a specimen sufficient for diagnosis, but it is now rechecking the EBUS, the more stable image was obtained. So re-advanced 1.7 millimeter cryo probe to this case, and not to straight the bronchoscope curve. So finally, we confirmed the biopsy site on the anterior view, then performed cryobiopsy with 3 seconds. And finally, casseting granular matter tissue was obtained, and PCR detected Mycobacterium avium. Thus, this case was diagnosed as a non-tuberculous mycobacterial infection. Summary for this case, even for peripheral thin bronchi, it is often possible and should be attempted to wedge the bronchoscope distally along the axis of an EBUS probe.
Yeah, thank you, Dr. Matsumoto. And it is a very great attempt to such a small region. So we don't have enough time. So please start the third case.
Okay. Okay, I will briefly. The next case, 74-year-old female with smoking history, and CT screening detected a small nodule. Chest radiograph doesn't show the apparent image, but CT shows this nodule. And the HRCT shows the related bronchus is left B9A. And of course, we approach this case using a bronchoscope, so I will keep on.
Yeah.
The virtual navigation image shows a related bronchus is left B9A small 1. And in accordance with our routine protocol, we first approach the region using a thin bronchoscope. However, the scope tip stopped at the left B9A. The top here is left B9A. It can be inserted, but stopped at this point. When we switch to fluoroscopy, our EBUS showed an adjacent to finding, allowing us to reach the region. However, unlike the previous case, even when pushing forward and our EBUS guidance, the scope could not be advanced distally, and a more distant approach was required. We then rotated the fluoroscopic view to the right anterior oblique position, but it was still difficult to obtain stable EBUS image. So we switched to MP scope. As demonstrated in my earlier presentation on the Ultrathin bronchoscope, we advanced the scope while injecting a small amount of oxygen through the channel via a nasal tube to dilate the bronchus. This revealed the steep branching towards the left, shown later. I'll skip a little bit. The MP scope can be inserted much more distally than thin scope, and here you can see the steep angle to the left way, and finally can be wedged to this small bronchus. And again, switch to the X-ray fluoroscopic view. Now we can stably get the EBUS adjacent to image. So here we perform biopsy using 1.1 Sinest 1. And again, reinserting the EBUS probe, now the scope also stably detected the EBUS adjacent image. And again, switch to the RAO view and scan the more posterior and lower side. Finally, we got EBUS within image. And at this point, we performed the second biopsy. And finally, histological examination revealed abundant mucus in the background with proliferation of tall columnar cells showing mild atypia. Based on these findings, the case was diagnosed as invasive mucinous adenocarcinoma. We have reported the biopsy specimens allow for identification of histological subtypes of adenocarcinoma, including the micropapillary type. And IMA is one of the variant types of adenocarcinoma, but it is often difficult to diagnose with conventional biopsy techniques because of the abundant mucus. So this case highlights the distinct value of high-quality cryobiopsy specimens. I will close my presentation.
Okay. Thank you very much. Wonderful cases. I would like to emphasize 2 points that are two tricks that should be used when you approach a nodule using the fluoroscopy. The first one is that you showed that fluoroscopy must be taken not in only one projection, but also the lateral view and the oblique view is very important to confirm the position of the probe. So for all the people that use fluoroscopy, don't forget to rotate the C arm because it's important, especially for small nodule, to have a lateral view and oblique view to be sure that the tool is in the lesion. And the second point that is very interesting, in my opinion, is that you use the radial probe as a guide to help the bronchoscope to progress toward the lesion. And this is another trick that could be very useful for people that are doing such kind of procedures. Well, now, Fumi, I think that we can go on with the questions. I have some questions.
But maybe the time is up.
The time is up, but we have 2-3 questions, so probably 1 minute, very, very quick answer.
Yeah. So
Sorry.
I have a question from who? So how long and how much of a pressure was given for balloon for bronchus dilation? It's about 20 to 30 seconds and just push manually, so not high pressure.
And another question is concerning the oxygen. How to use oxygen and how fast the oxygen in pressure is inserted to dilate the bronchus.
Dr. Matsumoto.
Okay, thank you for your questions. We usually inject 1 or 2 liter via the nasal catheter to attached to the working channel of bronchoscope. When attaching the nasal cannula, we pulling off the plug.
Yes, another question is concerning the surgery directly. Robert Silvka asked, do you perform histologic confirmation of every peripheral lung lesion, although it is clearly operable? This is an old problem. In my experience, the surgeon are happy if they have a confirmation of malignancy today. So if it's possible to get diagnosis before surgery, our surgeons are very happy. And they ask us to perform a biopsy, even if the nodule is clearly operable. Because you have seen the case of Naofumi that was an inflammatory lesion. And for surgeon is not the best to operate a patient with inflammatory lesion.
Yeah. As a result, yes. But she had a bladder cancer history, and we have to show the biopsy result. So we want to try to biopsy without surgery because her general situation is not good. So, but we have to show the pathological diagnosis. So finally, we decide to operate, but that was not malignant lesion. Yes.
Okay, I think that the time is over, so we have to move to the second session. I thank you very much, Naofumi, and all the speakers. because they gave us a lot of information and wonderful talk about some techniques to reach the peripheral lesions. Probably we will discuss again on this technology during this webinar. So please stay connected. Don't go for lunch or for dinner according to the time of your country, but remain at your computer because this webinar will provide further and further useful information for all the people that perform interventional pulmonology. Thank you very much and have a good day.
Thank you very much.
Thank you.
Thank you all. That concludes our first session of the day, and now we have a 3-minute break. And during this break, I ask you to draw your attention to just a very short video from one of our sponsors.
Depth, the valve is delivered with excellent circumferential adhesion. And there you see multiple Zephyr valves in place, made much easier by the flexibility of the AMBU A5 scope. Utilizing the AMBU A5 bronchoscope, here you can see a BAL being performed from the lingula with excellent optics, nice flexibility. We're utilizing the side sampler, which worked very well. Today, we're going to be doing an operative bronchoscopy. This time, a lady has recurrent severe tracheal stenosis. I'll be operating using the AMBU A5 disposable interventional bronchoscope. This is a patient with complete obstruction of the right mainstem bronchus with a friable tumor that was arising from the right upper lobe. We then placed a rigid bronchoscope into the patient, utilized APC via the AMBU A5, which afforded us not only clear optics, but quite a bit of flexibility. Here we're just cauterizing what's left of the tumor. Toward the end of the video, you can see down the right main stem with an open bronchus intermedius and nice photocoagulation of the right upper lobe tumor. The ability to rotate like more expensive interventional scopes was also quite advantageous, showing an endoscopic view of procedure of cryoablation of a tumor, utilizing the AMBU A5 scope that has been placed inside of a rigid bronchoscope where we are ablating endotracheal tumor. What makes this much easier is, number one, the optical clarity that we can slave to another monitor, but also utilizing the large 2.8 millimeter suction, which allows us to suction around the cryoablation catheter. Here we're using the AMBU A5 with the Zephyr delivery catheter in a difficult to access segment. And once it is measured for appropriate depth, the valve is delivered with excellent circumferential adhesion. And there you see multiple Zephyr valves in place, made much easier by the flexibility of the AMBU A5 scope. Utilizing the AMBU A5 bronchoscope, here you can see a BAL being performed from the lingula with excellent optics, nice flexibility. We're utilizing the side sampler, which worked very well. Nice extraction, nice performance.
Thank you all. And now I'd like to present to you session 2, navigation and robotic bronchoscopy.
Hi everyone, my name is Danai Khemasuwan, and also the co-chair session, Dr. Udit Chata. So I'll let Dr. Chata start the session.
Welcome everybody to this session on navigational and robotic bronchoscopy. And on behalf of Li Xieyu, Danai, and me, I would like to thank Ping for the invitation, and Ping and Mike for both organizing this so well. Our session has 4 talks in it. The first one will be by Dr. Sonali Sethi from Cleveland Clinic, and it will be about cost considerations and radiation with augmented fluoroscopy and CBCT. Sonali, I think you can share your screen now.
Thank you. You guys can hear me?
Loud and clear.
Okay. And can you see my slides?
Yes.
Yes.
Okay. Very good. Okay. Thank you, everyone. Good morning, good afternoon, good evening, wherever you are in the world. I myself just landed in Europe, and so it is fortunately the afternoon for me now. I know for Udit and Danai it is quite early morning for you guys. I want to very much thank the organizers for having us. This is an amazing, wonderful endeavor that you guys have put together. So I'm going to talk about augmented fluoroscopy versus cone beam CT, and we're going to talk about cost and radiation. And I think instead of augmented fluoroscopy, I think the better way to understand this is understanding the various imaging platforms that are out there, specifically digital tomosynthesis, because it's the digital tomosynthesis that allows you to have augmented fluoroscopy, and we'll compare that to cone beam. So I want to spend a lot of time on understanding the basics of imaging, and then we're going to bring in cost and radiation, and specifically talk about the white paper that the WABIP put out this past year. So I am going to start with an analogy. So a lot of you live in major cities. I used to live in a major city, and to get from point A to point B, I bet a lot of you would want to have some kind of fancy, luxurious kind of car that could get you around, such as a Bentley would be very nice to be able to get there. And However, we know it's not practical to be able to get from one point to the other point. And in fact, the better way to be able to do this is to get on a tube or get on a subway, which also gets you, not in as fancy of a manner, but also gets you from point A to B. And you're going to understand why I brought up this analogy in a minute. I'm going to start with cone beam CT imaging. This obviously is our gold standard. These are the images that we get every day. These are the images that we love. When we see these, they give us really nice, clear, crisp images of the lung. And what this is a patient obviously lays on a table. We have an X-ray tube, and there's a fan beam detector that's underneath. And the patient mobilizes through this tube, and this fan beam emitter spins around the patient multiple times. And what you're actually getting are X-ray images and hundreds of X-ray images, and they're piling themselves on top of each other. And we're getting these beautiful CAT scan images that we see. However, this is not cone beam CT. So although the word CT is in there, cone beam is not this same type of thing. And we're going to learn about that a little bit better. So in our regular bronchoscopy suites, we all have regular fluoroscopy machines, and every fluoroscopy machine you have, the regular one just sitting there, they all have what is called a cone beam emitter. So whether you have a fixed cone beam, a mobile cone beam, a fluoroscopy machine, they all have a cone beam emitter, which creates a clinically useful 2D image. So again, what you're getting is that X-ray image. The number of images that you get depends on the amount of rotation that particular machine is doing around the patient. So larger and higher end fluoroscopy systems can do 180 or more rotation. You get a lot of those X-ray images, just like the CAT scan images that come together to get you 3D imaging. That is called cone beam CT. However, your standard fluoroscopy machine can also not stay in a 2D imaging platform method. And in fact, that's how we all learned during our fellowships to do it. But we now have started to rotate them around a patient. So if you're doing 60 degrees to 90 degrees, you're also getting some images, not as many images as you are with the wider sweep. However, you're also getting images that can create 3D imaging. And this is what is called digital tomosynthesis. So going back to our analogy, cone beam CT imaging is the Bentley. It gives you really nice images. You're getting wider sweeps that are happening around the patient. However, you are still getting what you need from digital tomosynthesis, and this is with your regular fluoroscopy machines, or even your mobile cone beam if you're doing a limited sweep. You are still getting what you need. You are getting from point A to point B. So this is just a schematic that kind of shows you the difference between cone beam versus tomosynthesis. Again, it could be the same machine that you have here, the same fluoroscopy machine. It just depends on what is that sweep that you can do around the patient. So intraoperative tomosynthesis is an angle up to 90 degrees. And what this gets you is you get an LAO angle, that's an angle on the left, an angle on the right, and you get a coronal, and these give you a 3D view. With your mobile cone beam or intraoperative CT imaging or fixed cone beam, you're getting orbital angles up to 180 degrees. So this is giving you axial, coronal, and sagittal 3D views that you're getting. So this is an overview of the current imaging technology that is out there. So we already talked about CAT scan machines. We're going to break this down a little bit more. Obviously, CAT scan machines give us the best available imaging that is possible out there. That is our gold standard. This is then followed by the next best imaging we have is with fixed cone beam machines. However, these come at quite a cost and very limited access to us in our field. This is used by interventional radiologists. Some of us have been lucky enough to get access to these rooms. Then there's mobile cone beam now, which institutions are now starting to purchase that can get wheeled around the hospital or into your bronchoscopy suites. Less expensive, however, still expensive, about $400,000 US. Therefore, there's a limited number of systems installed. Imaging is very good with these. And then your regular fluoroscopy machine that everybody has now, which also can get you 3D imaging with specific navigation platforms and is cost effective. So starting with the fixed cone beam machines, these images are acquired through the use of a C-arm. You've all seen your interventional radiology suites. You get a high spatial resolution, high contrast resolution, you get a large field of view. The strengths of this is it gives you real-time lesion location information. It helps you to overcome CT to body divergence. You get that nice tool and lesion confirmation. And some of these have software that give you these nice augmented fluoroscopy images. This is taking the area or the target of interest on 3D imaging and superimposing it on 2D fluoroscopy imaging for intraoperative guidance when you are doing your biopsies. And we're going to talk about this a little bit more. Limitations of this, it's over $1 million, closer to 1.5 million US dollars, requires a dedicated room or access in a hybrid OR. And again, I said a lot of us have limited access to this. There's no integration specifically with the robotic platform, so it's two systems that you're using together. And there is quite a bit of a learning curve to learn and to understand the software that is associated with this. This is an example of the fixed cone beam machine. You can see how nice these images are that you see, the 3D reconstructions you get, the augmented fluoroscopy that you get here. And here you can see tool and lesion spins where you can see the tool right in the middle of the lesion in each of these images. Next, we'll go on to mobile cone beam. In the US, there currently are two mobile cone beam systems that are out there. They are each about $400,000 to $500,000. So cheaper than your fixed cone beam. There is the Siemens Sios and the GE OEC 3D. These are bulkier compared to their 2D mobile C-arms. In my suite, I have the Siemens. I have to mobilize it myself. I don't have a Fluorotech. It can be quite heavy. Scanning times do take time. It can take 30 seconds to scan. So it does add time to your procedure. And because of that, depending on how your settings are, there could be more radiation. The GE OEC has augmented fluoroscopy currently integrated into its software. The Siemens does not now as of yet. There's more chance of collision due to larger rotation range, and there's limited availability because of the cost of whether your institution can buy this for you on top of other navigation platforms that you may have. Now, going back just to remind you again, the difference between tomosynthesis and intraoperative CT imaging, we're now going to focus on tomosynthesis and what that imaging quality looks like for us. So where did tomosynthesis first come around? It's been around for a long time. In fact, was first used in breast images where they would do limited spins, and then you would get these beams that would get focused on the area of interest. They would go into a software that would get an algorithm that was there, and you would get these nice reconstructions, and you would be able to see these nodules. As you can see here, there's a nodule here in this breast. This can also be applied to our field using the regular fluoroscopy machines or even mobile cone beam machines. Again, it's all depending on the sweep, but can be applied to chest imaging where you do these limited spins around, and then these images go into a software program. They get reconstructed with an algorithm. And here on the right-hand side, you can see these nice nodules. You can see, in fact, you can see tool and lesion in both of these images. The quality of imaging is different between cone beam CT and between tomosynthesis. So this dog that you see in the middle of the screen, quite cute. This could be your lung nodule. And what you can see is with cone beam CT, because you're doing wider sweeps, you're getting nice crisp images. So you see the nodule, but you also see everything in the background that goes with it. That's why these are close to CAT scan images that you see. With tomo, what you have is limited sweeps that are happening, and therefore you see the object of interest very clearly. You can see the dog here very clearly. However, what is in the background is more shallow. So you're not getting that nice crisp thing. However, do you need to see all of that when you're going after a lung nodule or trying to biopsy a lung nodule? What is important in getting this nice image of the nodule or the dog? It's important to properly isocenter your beams onto the object of interest, and I'm going to talk about this a little bit more. So digital tomo has shallower depth of focus, as I showed you, and it's important to isocenter on the object of interest. So what you want is all the beams from your imaging as you're spinning around to come and lay right on top of where the nodule is, so that that is what you are seeing that is nice and crisp in your imaging. So if this is your CAT scan and you're going to do a spin of 30 to 30, what you want is all the beams to be right on top of that lung nodule to give you nice imaging. If the nodule is outside of isocentering, then it may not be good imaging that you're getting, and the image quality that you're getting may be poor. However, you don't need to be perfectly isocentered to get really good imaging with what you're seeing. In fact, the sweet spot is at about 25 millimeters. And in fact, if you're still within 40 millimeters of that nodule, you are going to get good imaging that you're going to see. So you might say, well, how do we know exactly how to isocenter over a lesion? How do I do that? Well, there are software programs over there that assist and help you to do this. For instance, this is Body Vision. Body Vision tells you exactly where to align your fluoroscopy machine, the height, and where to align it to be perfectly isocentered over the nodule to get good imaging. One of the robotic systems that are out there, and in fact, the Illumicite as well, the way they isocenter around the imaging is by having the tip of the scope near the nodule, and that helps you to get the beams in that area. By marking the tip, you know you're within a certain distance, and that's how you get that nice imaging that you see. Now, these are actual images of tomosynthesis and CAT scan imaging. I purposely blacked out on top which was the CAT scan imaging and which was the tomo, to give you an idea using 3 different platforms what your imaging actually looks like. So here, I think it's kind of obvious that the pre-op CT is on the left side, you can see there, but look at the SIOS-spin. So this is your mobile cone beam machine. This is my mobile cone beam machine that I have in my bronchoscopy suite. However, this was a limited spin. So this was a 30 to 30, so this was a tomo spin, and this is the imaging that you can see. You can see the nodule here quite nicely when you're isocentered on top of the nodule. Here's a different platform, again, utilized in my bronch suite. I have this one as well. And this is the GE 9900. And you can see how nice the imaging is compared to CAT scan imaging. And then lastly, this is actually the GE OEC. Again, tomo images. These are not cone beam CT images. So you can see here that you can see the nodule of interest with what you're doing. You may want to ask, well, how accurate is digital tomo compared to cone beam? And all the literature we have on this actually is from breast, since they've been doing this for quite a long time. And they found that from the center of the lesion in digital tomo, you are within 1 to 2 millimeters of cone beam imaging. So it's quite accurate. We're not going after 3 millimeter imaging. So I'm off by a millimeter or 2. That's okay. We're going after 8, 10, 15 millimeter nodules. So digital tomosynthesis is quite accurate. And so when you're looking at tool and lesion spins, in fact, on the top here, you can see cone beam images. So you have the SIOS imaging up here. You have the GE OEC 3D, nice images, Philips Azurian here. And on the bottom, with the GE 9900, you can see here with both the Body Vision and with the Galaxy, you can see a tool and lesion, and you can see how nice your imaging is with just tomosynthesis alone. So when we talk about radiation, it would make sense in your mind that if you were doing limited angle sweeps, that you were getting less radiation dose. However, what we are learning is that with our cone beam machines, there are things we can do with the settings to be able to go as low as reasonably achievable. And that is what everyone has been starting to do. So when we historically look at the literature, it's kind of difficult for us to say how low is the radiation with one versus the other, because no one out there in their papers, when we go back and look, have been reporting things the same. And that's where I really want to congratulate the World Congress for publishing this white paper that recently came out this past year. I would encourage all of you to read this paper. I think it's a very important paper. This isn't a fluoroscopy talk I'm giving radiation talk I'm giving to you. However, what they are asking is that we all start to report things equivalent, so that we can actually accurately gather the data that we need, so that we can actually tell what are the differences between the settings we're using, the cone beam machines, tomosynthesis, And the things that they're asking us to look at specifically are the BMI. They're asking us to look at the dose area product, the CAK, the number of scans that we're doing, what are the total scan DAP and CAKs, and to all do this consistently in all of our papers moving forward. The other thing they did is they shared with us a table on what average doses look like, so we can compare what our doses look like when we're comparing to what a chest CT scan is, a low-dose CT scan is, and then other procedures that are done by our colleagues, specifically interventional cardiologists and radiologists with their TTNAs and angiographies that get done. So what else can we do with DT imaging integration that we get? So you can do target location updates. So you overcome CT to body divergence. So you see real-time nodule, you can update the nodule. You can use augmented fluoroscopy with this. So digital tomo and augmented fluoroscopy go hand in hand, and I'm going to go into that a little bit more. And then you have targeting functions that help you to get right on top of the nodule. So again, I said that AF is basically your target of interest on 3D imaging that is then superimposed onto 2D fluoroscopy. So here you can see you do not have augmented fluoroscopy. And I want to point out, I know we can see the nodule here. This was done in a test, but we can see the nodule here. But most of the times our nodules are not fluorovisible. So you can see without the augmented fluoroscopy, your needle is coming out, you're not hitting the lesion. If you couldn't see your lesion, you wouldn't know that. However, with augmented fluoroscopy that's overlaid on your imaging, you have a blue circle here. It tells you exactly where that nodule is for you to be able to visibly be able to biopsy it. So this is, you then spin around into LAO, RAO, and AP. So you go into different views. You don't have to do full tomo spins, so less radiation. You just go into spot views. Here you can see you're on the edge of the target in LAO. You're on the edge of it in AP. And here in RAO, you're actually not in it. So in this, you actually are anterior to the lesion, and therefore you would need to readjust to get in it. So not having to do a full spin, again, less radiation that people are being exposed to. In conclusion, this is a very complicated kind of table, but what I'm trying to reiterate here is in the cone beam systems, there's mobile cone beam machines, there are fixed cone beam machines, both give you good quality at higher radiation doses you're seeing here. And then there's tomo imaging that also has AI-powered tomo imaging to give you nice 3D imaging. So you get nice imaging with that. And we could imagine that would be at less radiation. So this is a nice table I put together. Both digital tomosynthesis and cone beam CT have good image quality. I hope I convinced you of that for the procedure, showing you various images throughout this. Spin time. So time does get added with cone beam CT. It takes several minutes for the processing time, and digital tomo is fast. It's a limited sweep. And if you have augmented fluoro, in fact, it's even less because you can do spot checks. Radiation, less with digital tomo. Cost, much cheaper with digital tomo compared to cone beam CT, which is at about 400,000 up to 1.5 million if it's fixed. Augmented fluoro, yes, with digital tomo, limited with cone beam, depending on your technology, and both can give you a tool and lesion spin. So I would encourage you that not to stay stagnant with your machines anymore. Use whatever you have in your hospital. Start spinning it around lesions. If your hospital is nice enough to get you a mobile cone beam, that's great. Whatever it is that we do, imaging is very important for our navigation platform so we can be as accurate and know exactly what we're looking at nowadays. And so it definitely needs to be incorporated into all of our platforms now. And with that, I will stop sharing.
Thank you, Sonali. We'll save questions for the end, time permitting. I think we'll move on to the next talk, which is by Danai Khemasuwan from Virginia Commonwealth University in Richmond, Virginia. You're in the USA. Danai, can you share a screen?
Yes, thank you. All right, so thank you for WABIP for the opportunity here. All right, let me make sure. Okay, you see my slide, okay?
Yep.
All right.
You're
All
just
right,
on presenter. You're on presenter mode. Just go to full screen.
Full screen. Okay. How about now?
Yep.
Okay. All right. So my talk is on the patient selection and workflow integration for robotic bronchoscopy. No financial disclosure linked to this talk. So I just want to convince our audience that's why lung cancer screening is very important for the patient care. So in terms of the diagnosis, we know that lung cancer has the lowest 5-year survival due to the diagnostic delay. So the survival is less over time with the distant metastasis in the patient comes. So if we can get the patient diagnosis sooner, the survival is better. And then also the healthcare costs. This is the paper from Tom Guday back in 2017, the data from mostly from North America. So basically about the 70% of the patient come at stage 3B or stage 4, which is a non-surgical. As you can see that the cost of care is almost double or triple compared to the earlier stage. And the problem is clinical challenges for the early stage cancer are the nodule are small. In the stage 1 is about 1 to 2 centimeter. 70% of the nodule are located 1/3 of the lungs, and then mostly in the upper lobe. And also half of that is no airway leads to it or bronchial sign. So it makes it quite challenging to get to those nodules. That's how robotic bronchoscopy come into the play. One quick slide mentioned about how do we can get the patient to the door as a workflow. As the data from the North America, many of the patients that come to us with the incidental nodule programs, the patient get the CT scan from any diagnostic reason and come to us to get the biopsy. And also the huge gap opportunity for the lung cancer screening. So as the data from the Medicare database, we have about 14 million patients that eligible for screening. However, only about 5% that patient got screened. So that's a huge gap opportunity that we can do to get the patient to us. So this is a basic models of the robotic bronchoscopy. So we can get the patient to us by those two programs that I mentioned earlier. It can increase the early diagnosis and will come down to the increased treatment and downstream revenue. So a lot of speaker already mentioned about this. We start about in 2004 with introduction of the super dimension, which is electromagnetic navigation from Medtronics. A few years after variant system from Olympus come into the play, and those system has been in the market for quite some time until the first robotic come in with the Monarch. A few years after that, Ion Pharmaceutical come into the market with the chip sensing technology, slightly different from the other platform. And then Elamosite from Medtronic, which is the EMN, and then integrated digital tomosynthesis in 2019. And then 2023, the Galaxy, which is also EMN based, into the market, commercially available. So quickly look into the cross section of the scope. The left panel is Olympus bronchoscope with about 6 millimeter of the outside diameter with the working channel of 2.8. The next three are the robotic. So Monarch, the Chih is about similar. It's a 6 millimeter, but the scope that can extend it's about 4 millimeter. And then Galaxy is about the same, about 4 millimeter. And Ion slightly smaller, but there's no vision when you perform the biopsy. So this is the data from Mayo Clinic group a few years ago. It's a multi-center retrospective study comparing between robot assisted bronchoscopy and CT guided bronchoscopy. The diagnostic yield is very similar, about the close to 90%, and with robotic bronchoscopy has a way lower complication rate. Mostly will be pneumothorax. And the benefit of robotic is and can also integrate it into the workflow for the staging at the same time. And this is hot off the press, just published from New England Journal. I'm sure that many of you have seen the paper. It's from the IPOC group that leads by the Vanderbilt. Basically, use the comparison between navigational bronchoscopy, which is a lumosite system, as I mentioned earlier, compared to the transthoracic needle biopsy. This is a multi-center randomized and non-inferiority trial compare the diagnostic yield from the nodule between 10 to 30 millimeter. So the conclusion is that the final diagnosis from navigation is about 80%, slightly better than the CT guided, but we have a way lower pneumothorax rate. It's about 3% for navigation compared to 28% for the CT guided. So for the patient selection and workflow, so I have a few topics here. So we start with the pretest probabilities. As Professor Gasparini mentioned, that's all the nodule is malignancy, right? So we have to come down to the context of the patient. What's the pretest probabilities? We can use the online Mayo model or Brock models to see how much of the risk of the patient. And we have some biomarker that can guide us as well in this current technology. And we'll start with the lesion, mostly between 10 to 30 millimeters. Anything bigger than 3 centimeter, regular bronchoscopy and radial EBUS can probably get to it. Anything smaller, maybe wet and wash, depends on what technology you have in the system. To start, a lower cost option would be radial EBUS or 2D fluoroscopy. If you have more financial support for institution, we can go for higher costs, like Dr. Stonali mentioned, about using the digital tomosynthesis or cone beam CT to encounter the CT to body divergence. Also can show twin lesions, and some robotic system can also allow registration for more precision to biopsy. And then another consideration is sedation and anesthesia. So as you may know that the atelectasis during the bronchoscopy can occur as early as 3 minutes. So if you have lesion in the gravity dependent in the lower lobe, it may be more difficult to perform the biopsy and even get the radio signal. So the vent strategy come to play a few publication in the past. So we minimize the FiO2 to decrease the absorption atelectasis, use a higher PEEP like 10 to 15, depends on the patient body habitus. Also, if the lesion in the posterior, you can do the prone position biopsy. If the lesion in the lower lobe, consider a breath hole during the biopsy, which may help to improve the accuracy. For as a tool, as other prior speaker had mentioned, needle forceps or using the 1.1 cryoprobe, that would be very helpful. As the program maturity, you have more tools and advanced imaging. You can go for the smaller option nodules. And also, as I mentioned, that you can do staging EBUS at the same time. There's a question that you should do the staging EBUS first for the bigger lesions, or you do the robotic or navigation first. There's an ongoing trial called sequence trial happening in North America. So hopefully the data will come in a year or two. And also you can have a rapid on-site examination can provide a feedback to the operator and the real time. So we'll come down to the post procedures and metrics. As far as the workflow after the biopsy, if that non-diagnostic, it's very important to have a multidisciplinary between the medical oncology, radiation oncology, and thoracic surgeon. In the panel, we discuss the case to see what would be the next best step for the patient. Option could be from close monitoring with imaging, repeat bronchoscopy with more advanced imaging, CT-guided TTNA, or go straight to surgery. Will come down to a decision what would be the best for the patients. And also the program should track some quality metrics, including the tools enrichment rate, diagnostic yield, could be liberal, could be strict, depends on the institutional goals, and then complication rate, pneumothorax if the patient needs chest tube or sometime monitoring in the hospital. And also as far as the program is time to diagnosis and time to treatment, that we want to decrease that to decrease the barrier to care. Come down to the capture the downstream revenue. So with the advanced early diagnosis, it can have a early stage shift, and also the downstream revenue. There's a paper in the thoracic surgery that show that the thoracic surgery can generate up to the $41,000 for the procedure, and with the similar financial models can show that the adjunct other therapy, including chemotherapy and radiation therapy, can increase the reimbursement as well. So again, multidisciplinary best practice, lung nodule recognition with the screening, lung nodule navigator to get the patient to the door, evaluation pre-procedure risk calculations, diagnostic efficiency with the bronchoscopy, staging robotic bronchoscopy, and MDT with oncology and thoracic surgery. So this is the teamwork. It's not the single person that can do all this. And then for the take-home messages, early detection and diagnosis save life and decrease the cost of care. Two programs that come hands in hands in incidental lung nodule and lung cancer screening programs. Careful patient selection, risk stratification, and as the program expands, so you can get more patients, get to smaller nodules, and can diagnose it earlier. Integrated robotic bronchoscopy in lung cancer care workflow. And lastly, our multidisciplinary is the best practice as a friend. So my email is below. With the sake of time, I will return this to Dr. Shada, and then we can play the video from Dr. Mergu. Thank you.
I think Tim Murgu's presentation, which is a recorded presentation, is next. Mike Mendoza will be playing that in just a minute. If you all have questions, please put it in the chat box and we'll try to address it during the case discussion section.
Hi, my name is Tim Murgu from University of Chicago, and I appreciate the opportunity to speak to you on this topic. My objectives are to list strategies that could diminish the city-to-body divergence. I believe that's particularly useful for those who do not use external imaging. I will enumerate ventilation strategies that can improve visualization as we navigate towards the periphery of the lung and also prevent atelectasis. And at the end, I will review some logistical matters that may be practical for your bronchoscopy suite as they are for mine. So if we define divergence as an overlap of less than 10% between the target location on the pre-procedural CT and the target location during real-time imaging, which of the following you think is true? It's documented in more than 50% of the nodules. It's more pronounced in the upper lobes than in the lower lobes. Is not affected by general anesthesia and ventilation strategies, and is only seen with electromagnetic navigation-based bronchoscopy. Which one do you think is true? Correct answer is A, as it was shown by Janani Reisenauer and her colleagues in a paper from Mayo Clinic. The authors looked at the lesion location on the pre-procedural CT and then during mobile cone beam CT using the ION system. And they found this phenomenon being present in 50% of nodules. In fact, it is more common in the lower lobes than in the upper lobes. And they actually use the ION system, not an electromagnetic navigation-based robot. So the problem seems to be pervasive across technologies. However, I will raise a question of skepticism in regards to how responsible is this phenomenon for affecting diagnostic yield. I think we all know that the city-to-body divergence exists. We indeed see it mostly in the lower lobes, not so much in the upper lobes. We're always worried that we may be biopsying normal lung while we think we're biopsying the lesion. But in the largest studies performed to date, one with the super dimension, the Navigate study, and the robotic bronchoscopy study, the Target trial, looking at hundreds of patients, the lesion location did not affect diagnostic yield. In the multivariate analyses in the Navigate and univariate analyses in the Target study. For Target study, actually, we did not find that location affected diagnostic yield regardless of the definition that we applied. So yes, it's a real phenomenon. It's something to be addressed. However, if that truly affects diagnostic yield or not, it still remains to be determined. Now, why does it happen? For a variety of reasons. Number one, the CT scan that we use for planning a procedure is done at the total lung capacity as patients take a deep breath and hold their breath during scanning. Well, under general anesthesia, the lung will deflate. The lung functions at usually at functional residual capacity. So the lung volume will be much smaller than prior to the procedure during spontaneous ventilation. In addition, as patients are asleep, because during positive pressure ventilation, air follows the path of least resistance, the upper lobes will be ventilated more than the lower lobes, and the atelectasis kicks in, which is definitely more prevalent in the lower lobes than in the upper lobes, as was shown in a variety of studies. Atelectasis, once it develops in segmental and subsegmental airways, that can lead to even more lung shrinkage and even more CT to body divergence. In fact, Dr. Krish Badra and Mike Pritchett, in one of their papers from 2022, showed that atelectasis, as interpreted by two radiologists, was seen in more than 2/3 of patients. In fact, in a third of patients was so bad that the actual target lesion was completely obscured. And this is with the cone beam CT imaging. What they also showed is that if you open up the lung with certain ventilation strategy, that phenomenon of atelectasis can be diminished, but not completely canceled. And what volumes did they use and what settings did they use? They actually use a pretty generous tidal volume of 10 to 12 milliliters per kilogram ideal body weight, and PEEP, which was pretty high of 15 and 20, especially for the lower lobe lesions and in patients with obesity. They also use recruitment maneuver during the actual scanning with cone beam CT or tomosynthesis. The phenomenon of atelectasis has been also documented in studies looking at radial endobronchial ultrasound, like in the paper from Ali Sagar and with the senior author Roberto Casal, showing that as early as 3 minutes after induction of general anesthesia, atelectasis can develop. But the median time was about half hour. BMI was an independent risk factor. So yes, this phenomenon is seen especially with patients with obesity or morbid obesity. And also importantly, the image of atelectasis on the radial EBUS could mimic imaging of a nodule or a mass, and that can be misleading to the operator. I would point out, though, that bronchoscopists who are experienced with endobronchial ultrasound, they recognize a variety of patterns on radial EBUS. In fact, a paper from more than 2 decades ago from chest in 2002 by Dr. Noriaki Kurimoto, they describe 6 patterns of lesions when it comes to lung nodules and tumors on radial EBUS. I mean, you can see patent vessels, you can see patent airways, and some nodules are, some areas are completely atelectatic, and some, the architecture of the lung is being maintained. So in expert hands, confusing a radial EBUS image of atelectasis from a nodule, I don't think is that common. Especially when we were talking about experts in the field like Dr. Felix Hurt, Eberhardt, Alex Chen, with a lot of experience in reading radial EBUS images. But what it is also true is that even when we localize a lesion accurately with the radial EBUS, diagnostic yield is still 20-25% lower than the localization rate, even when we know real time or in the lesion. So again, things that are responsible for a low diagnostic yield is not just the CT to body divergence. In fact, even in the robotic bronchoscopy times, we know we can reach the lesion and see it on radial EBUS about 90% of the time, and yet diagnostic yield is much lower than that. So yes, it is important to prevent atelectasis. It is important to move relatively fast during the procedure. However, that is not city-to-body divergence, and atelectasis are not the only factors contributing to a suboptimal diagnostic yield. But it's something that we should be addressing, and there is a lot of attention in the literature to it, and it's something that we also try to mitigate in our practice. So here is a question. Which of the following maneuvers can be performed to improve visualization and prevent atelectasis while navigating in the periphery of the lung? Increase the PEEP after wedging the sheath or the scope, depending on which technology you use. Increasing the FiO2 immediately post-intubation. Injecting air through the working channel of the scope, robotic or not, and always orient the scope towards the virtual target. I would say that increasing PEEP once the sheath or the bronchoscope is completely wedged into a segment or subsegment makes no physiologic sense. Once the scope is there, if it's truly wedged properly, then whatever air we give with positive pressure will follow the path of least resistance, will go to the adjacent airways and potentially hyperinflate the segments around our target segment, potentially worsening the atelectasis. So while we do perform PEEP and give higher volumes of do recruitment maneuvers, I personally believe that those maneuvers tend to be more effective in terms of preventing atelectasis prior to wedging the scope. They may be effective in stabilizing the lesion during the actual sampling or during an injection, but for the purpose of preventing atelectasis, those maneuvers will unlikely work once the scope is wedged. Orienting the scope towards the target it may also be wrong unless we're actually ready to sample and we reached an optimal distance. And why is that? Well, for one thing, when we orient the scope towards the target and not staying in the center of the airway, we lose vision. And two, we may actually deform the airway, and by deforming the airway, that can lead to even more city-to-body divergence. So yes, we're orienting the scope towards the target when we're close to it and ready to biopsy, but not during the actual navigation. If the airway is collapsing in front of us, like it happens in patients with severe emphysema or morbid obesity, there are other things we can do. One thing I do is opening the system completely to atmospheric pressure, and that just allows the pressures to equilibrate, and airway may open up, because sometimes the collapse is also due to the fact that there is some capillary action as we advance the camera. If that doesn't work, then we inject some air, and as you can see in this image, the airway can be splinted open. That not only improves visualization as we continue to navigate in the periphery, but also prevents atelectasis. All right, back to atelectasis. Which of the following is true from the VESPA trial regarding ventilatory strategies to prevent atelectasis during bronchoscopy? Any atelectasis was seen in 30% of patients in the intervention arm at 20 to 30 minutes after induction. Low tidal volume and recruitment maneuvers had no effect on mitigating atelectasis. In the intervention arm, the mean FiO2 of 70% was needed to keep the saturation greater than 94%. And the immediately post-induction of general anesthesia, there is no atelectasis based on cone beam CT or radial EBUS evaluation. Which one do you think is true? The answer is A, as we learned from the VESPA trial designed and performed by Dr. Roberto Casal. Vespa, as you know, is a famous motorcycle. I don't know if Roberto likes that bike or not, but it's a cool acronym for this randomized control trial. So the intervention arm, patients had a low tidal volume of 6 to 8 mLs per kg, ideal body weight, a recruitment maneuver, and PEEP of 8 to 10. The FiO2 was the lowest to achieve a saturation of 94%. It turns out the mean FiO2 was 50%, not 70%. The control arm had PEEP of 0 and the FiO2 of 100% with the same tidal volume. So what the authors found is that the intervention arm, again, with a higher PEEP and the lower FiO2, there was 30% atelectasis. In the control arm, 84%. That's a 20 to 30 minutes after induction of general anesthesia. So a significant improvement by opening up the lung a little bit and by not doing a nitrogen washout with too much oxygen. Interestingly, there were no cases of pneumothorax or pneumomediastinum in the intervention group. However, the authors are very candid in acknowledging that only a minority of patients had actually biopsy in the periphery of the lung. So here are a few things that we do in our practice. Both when we use the Monarch system and now with the Galaxy system, initially when we start, we keep the C-arm away from the bed to avoid that interference during the actual registration. Then the patient gets intubated, usually with an endotracheal tube of 8.5. We have used smaller, we have used even 7.5 with the system that we're using, Galaxy. Ideally, the tube should be in the center of the airway. We typically park it at 4 centimeters above the carina. However, if we work into the upper lobes, especially in the right upper lobe, in order to provide a little more stiffness to the bronchoscope, we park the scope in the lower trachea. Then we perform an airway inspection, we clear the secretions, we avoid injecting saline to avoid more alveolar filling. We adjust the PEEP, decrease the low volumes, keep the saturation just to keep, decrease the FiO2 to keep the sats in the safe range, and then occasionally perform a recruitment maneuver. So not any different than Vespa. And then we have to adjust from time to time because sometimes the setup is not standard like here. Sometimes we have to figure out how we can connect the robotic arm to a tracheostomy patient, like in here using extension tubing. So I think we learn a lot as we go, and here are a few things that I have learned to do in order to prevent this phenomenon of atelectasis and CT to body divergence. If timing is so important, if truly atelectasis develops so early after induction, then we kind of have to move fast as we go towards the lesion. So you typically do a mental plan. I write on a piece of paper or I memorize, all right, I'm going into this segment, like in this case in RB1, and then I make a few turns and I write them down. And then I know I'm at the target. That helps in case the navigation system fails us, or if the navigation, the pathway that we created is not totally accurate. By the way, in regards to the pathway, as we review them on the CT scan, I also make sure that the pathway I created kind of follows the normal airway anatomy, where the daughter airways split from the mother airway at an angle that's obtuse. If you see a pathway where there is a very sharp angle, that does not follow the normal airway anatomy. The airways do not split at 90 degrees once we get into the periphery of the lung. So careful to the pathway prior to starting the procedure. And then we're learning more about this from also from the MD Anderson group. There may be a role for lateral decubitus positioning. I know there is a paper that was already published in JOBIP on this. This will also be addressing the incoming issue on the newsletter from the WABIP by Dr. Mona Sarkis and Roberto Casal. And I am aware there is an ongoing study looking at lateral decubitus versus Vespa. So stay tuned because that's something that we may be able to implement in patients with very dependent lesions and patients with obesity. So here are my 5 do's and don'ts for mitigating CT to body divergence and atelectasis. Instead of take-home messages, I will say this: do perform a recruitment maneuver and increase the PEEP, but prior to wedging the sheath or the scope. Do inject air. 60 ml syringe can be used for that. If airway collapses as you drive towards the target, do equilibrate the pressures by opening the proximal valve of the robotic system or the bronchoscope. That will allow equilibration of pressures and potentially opening up the distal airway. Do use the Vespa protocol for normal weight patients and for lesions in the upper lobes, middle lobe lesions. And do consider lateral decubitus for dependent lesions or for patients who have severe obesity. Do not deform the airway as you navigate to the lesion, because that will increase the CT to body divergence. Do not inject saline, as not only occludes the view, but it can cause atelectasis and affect the deep quick stain. Do not suction unless it's absolutely necessary. Again, suctioning will cause more atelectasis. Do not use high volumes and high PEEP in patients with severe emphysema, because they are not as prone to atelectasis and may increase the risk of pneumothorax. And similarly, do not use high PEEP and high pressures in patients with a low BMI, because also they don't develop atelectasis as often, and they are also prone to more pneumothoraces. I thank you so much for your attention, and enjoy the rest of the program.
All right, that's great. I would like to encourage the audience to type the question into the Q&A box. And then after Dr. Shatar's session, we'll go through that. We have a few minutes for questions. Thank you.
Danai, can you see my slides?
Yes, yes.
Okay, thank you. So my talk is about 3 challenging cases of prowess and regret, but it's more a talk about some learning points that I want to highlight in each case rather than the case-specific findings. And given that we are a little bit behind on time, I'm going to focus on what I think are important learning and highlight points in these cases. Now, I have no financial COI, but I would say that my system of use for navigation is the ION robotic system. And I use either a Radial EBUS with 2D fluoro or a CEOS cone beam CT. So again, what you use depends on what's available at your shop, your expertise, and your skills. So I'm no way trying to emphasize that the system I am using is useful for the sampling we need in these cases. So the case 1 is, do we always need to sample? And this is a 65-year-old male smoker. He had an incidentally detected part solid nodule. The nodule was slowly growing over the last 2 years with an increasing solid component. And you can see this in the left upper lobe. The nodule is highlighted over there, a clearly seen part solid nodule with a good solid component. So we sampled this with ion robot and cone beam CT. The pathology showed an adenocarcinoma. 2 weeks later, the patient had a VATS and the path was confirmed. Now, we know that with previous generation navigation systems, there's been a large number of studies, predominantly from Super D, and largely the diagnostic yield has been about 70%. There are big caveats in the definition of diagnostic yield, and they cannot be compared across all studies depending on what definition was used and what the cancer prevalence was in each of those studies. But in general, as a ballpark number, 70% was what we used. And once the robots came in with the first generation robotic systems, we noticed that there is about a 70 to 80% yield and hopefully a trend of improving yield with time. However, we still didn't hit that golden 90% that we wanted. Again, all caveats of diagnostic yield definition factored in. Has advanced imaging then translated into an improved clinical benefit? And there are a few studies with the ION system and a couple with the Galaxy system, and we are tending to see that the yields are now touching that golden 90% mark. But again, this depends on cancer prevalence in the cohort that was studied. So what I will say is that the additive value of cone beam CT and autofluorescence is, of course, to confirm your tool is in the lesion and avoid all the bad things that can happen with CT to body divergence. Now, it is not convincingly demonstrated yet because there's no good randomized control trial, but there is likely an additive value. Now, additive value does not necessarily mean clinical value. What do I mean by that? In this case that I presented, it is clearly an adenocarcinoma. And what do I mean by that? If this nodule was referred to me by a surgeon to biopsy, my question to them should be, will you believe a negative biopsy? And if the answer to that is no, then why am I really biopsying this? Because the differential diagnosis in a case like this of a slowly growing part solid nodule with increasing solid component is very, very likely adenocarcinoma alone. So should I have biopsied this is the real question. And every nodule does not need to be biopsied. Some can be resected straight away and many can be watched. Now, the value of robotic systems is also not just biopsying, but is also to place fiducials, because some of these part solid nodules are hard to track for surgeons intraoperatively and impossible to feel. And this is an example of a fiducial placed. As you can see in the center piece here, the metal piece is where the tumor was, and the line is the fiducial marker placed within the tumor. And this is another view of that placed during the robotic bronchoscopy. And these fiducials really are helping our surgeons to localize lesions better, especially when they want to perform sublobar resections or even wedge resections in patients with limited lung function. So my case 2 highlights to individualize your approach. Now, this is a 67-year-old female with thymoma, and she is now 4 years later found to have some pleural-based solid nodules, which are slowly growing, suspicious to be metastatic. So we discussed different approaches, and the shared decision was to proceed with a bronchoscopy. And this is the nodule in picture. And we used a COS plus a Radial EBUS combination to basically sample the largest nodule, which you see is dependent subpleurally, posteriorly down at the base. And cryobiopsies did confirm that these are thymoma mets. However, the procedure was complicated by a small pneumothorax, did not require chest tube, but did require observation for a few hours. So the question really is, we quote very clearly that the pneumothorax rate with navigational bronchoscopy is much lower. And if you look at all guided bronchoscopy studies, most of them quote a rate less than 4%, and only about a 3.3% rate of needing a chest tube, which is pretty much similar, slightly higher than the rate that was in Veritas. But again, in general, you see that the pneumothorax rates are pretty low. Of those who get a pneumothorax, maybe the chest tube percentage is slightly higher than you would see on the left of the screen, which is in the CT guided biopsy studies, where there's a median pneumothorax rate of 23 and 11.5 in of them in the Veritas, or 6.5% of total overall, if you look at the studies, needed a chest tube. So it seems that in most of the studies, CT guided biopsies are associated with a higher pneumothorax rate, but the percentage of those needing a chest tube is only about 6 to 11. So my conclusion is all pneumothoraces aren't necessarily the same, because we know that in the pneumothorax risk isn't the same, because a longer needle path, the need to cross a fissure, etc., will be associated with a greater pneumothorax risk. But the pneumothorax risk is not the same for a nodule like I showed you. When you're doing a CT guided biopsy for a nodule that is subpleural, I cannot quote to the patient that your pneumothorax rate is going to be 25, 30%. It's different when you're going across a bleb, going across a fissure, going deep into the parenchyma. So in general, while the risk is lower, we have to individualize. And is the question again, and the learning point for me in this case, is that the pneumothorax risk for pleural-based lesions that are accessible via percutaneous systems, the discussion has to be slightly different than a general 1 to 3% versus 25 to 30% pneumothorax rate that we have. But keep in mind, bronchoscopy also has advantages that we can stage lesions when it is necessary, and we can sample multiple lesions, as I had in this case, where there's a middle lobe and a lower lobe lesion. Both were synchronous primary adenocarcinomas with negative hilar and mediastinal lymph nodes. And again, it was highlighted in Tim Murgu's talk, so I won't spend much time in this. And using ventilatory strategies will help us get these dependent lesions better. And atelectasis prevention strategies, like was used in VESPA, are a no cost and low risk in most cases, and therefore should be considered, at least in most cases, especially when the nodules are dependent and those areas of the lung are prone to atelectasis, and also in cases where the patients have high BMI. The impact on diagnostic yield is intuitive, but it is not yet proven. Now, one thing I would say that the sequence trial is looking at whether you do the staging EBUS first or the bronchoscopy first, but based on a Monte Carlo simulation that was published in 2022, it seems like a guided bronchoscopy first approach is better for a higher yield. And that does make sense, because the longer you go into the case, the more the atelectasis, the more the CT to body divergence, and the tougher it'll be to get an answer. We do use advanced imaging, but is it always needed? And that my next case will focus on that. So this is a 42-year-old male with renal cell cancer, had some solid nodules that were suspicious to be metastatic. And we discussed biopsy versus monitoring, and the shared decision between the oncologist, us, and the patient was to proceed with the biopsy. Now, using cone beam CT and radial EBUS, we could have got to this lesion, but we started off with the radial EBUS alone and were able to visualize and sample the lesion. And the question really then comes is, do we need advanced imaging for every single case? Now, this is a small nodule, but what about a 2-centimeter nodule? What about 2.5, 3-centimeter nodule or mass? Then do we always need to use cone beam CT? And it has been highlighted in Sonali's talk that there is a radiation component, no doubt. Now, in one of the well-conducted studies in Respirology 2024, the amount of radiation exposure was well below recommended thresholds. But of course, there is a cumulative radiation dose to the patient and the staff. And that depends on not only where your biopsy targets are, the patient's body habitus, the lesion you're going for, and how easy and difficult it is, and how many spins you need to take. So there's a radiation exposure, there's a cost, and there is time to something like cone beam CT. And of course, there's a value, and the value is that there is CT to body divergence, and real-time confirmation will help you in many cases. But what I'm trying to highlight here is that this may not be in all the cases. So the CT to body divergence is clear, as Tim Murgo also highlighted, that our localization success is much higher than our diagnostic yield. So maybe it is CT to body divergence that is causing this. But I want to highlight something different here, that in my opinion, if your robotic scope is right next to the nodule, within a centimeter or closer to the nodule, your airway and the nodule will move largely in sync. And even with a radial probe, if you are not exactly on the nodule, with a little bit of cloud panning, you should be able to find it. So the CT to body divergence will matter a lot lesser if you can navigate to the lesion. And there's no proof of this that I can provide you other than a small cadaveric study and my experience. And in the cadaveric study, basically a multivariate analysis confirmed that the strongest predictor for a center hit with a robotic catheter was the distance of the catheter from the nodule. So what I want to highlight is it's not just the CT to body divergence. One of the big reasons our diagnostic yields are not matching our localization yields, our localization success, is probably the tool. We are still using old forceps and needles, which have been around for decades. And recently now, most providers have shifted to this, which is transbronchial cryobiopsy, where you can see in this case, a 1.1 millimeter cryoprobe is advanced through the robot catheter, and you pull it out with the robot still wedged, which is very important, which makes it safe and avoids the bleeding risk that you would think that you would have with cryobiopsies, because we all have that with the ILD experience. It's not the same. These are very safe, and they do provide visually bigger tissue. But importantly, you can see in all these studies where cryobiopsies were used, the yields were around 90%. And more importantly, look at the tools that were used with the forceps and the needle compared to the cryoprobes in green. In every study that compared different tools to a cryoprobe, you see that the cryoprobe was able to diagnose cases by in of itself and significantly increase the overall yield compared to overall other tools. And one of the reasons I also feel this is true is because cryo allows you to get a 360-degree tissue acquisition, which will compensate for you not being in nodule with a center hit every single time. So my learning points here is navigation success does not mean diagnostic success. The additive yield for cone beam CT and autofluorescent and augmented fluoroscopy is likely, still has to be convincingly demonstrated in a randomized controlled trial. My advice is to use them selectively because there's a radiation exposure cost and time factor that we have to factor in for these. Cryobiopsies are safe and they seem to add additive value. Routine use obviously cannot be recommended due to cost considerations, but at least in eccentric lesions and small nodules, it is my routine to use cryobiopsies to increase our yield. And that is my last slide. Thank you. Danai, I think we have a couple of minutes for questions.
Yeah, great talk, Shata. Yes, we have a few minutes, but I haven't seen the question on the question box yet. So we have 3 minutes. We
If
can.
there's no questions, then I can ask you one question. What is your, since we're talking about tools and you spoke about workflow, how do you use cryobiopsies, or what is your workflow with the choice of tool that you use?
Yeah, so in my practice, I also use ion in my robot. So as far as the tool, I actually start with the needle and forceps to start, just because of the most of the time the forceps and needles can get diagnosis, right? And adding the cryo may more cost. It's few more $100. We have system available. So if the forceps and needle doesn't give me the answer, we have both as well if I don't have diagnosis. So I will use the cryobiopsy as adjunct. So it comes down to about like 1/3 the case that I need the cryo to get to diagnosis. How about we can ask Sonali as well, Dr. Sethi, how's it doing in your practice?
Yeah, I don't tend to open up the cryoprobe right away at the beginning because there is a cost associated with this. First, it's about $400 to $450. But I do believe that additive tools are very important when you're doing this, meaning you don't just stick to one tool. The more tools you use, and we've shown that over and over in studies, the higher the chance you have of getting a diagnostic yield. So I'll generally start with a needle. If I get it on a needle, I do have rows and on-site cytology. If I get it, then I will just go to forceps, make sure I have a lot of tissue. If not, at that point, I will add usually a triple needle brush. If not, then I'm at that point, if I'm still non-diagnostic, that is when I'm thinking of opening up a cryoprobe at that point in time to utilize for my biopsies.
Yes, that's great. All right. There's a question. What diameter of cryoprobe do you mostly use for peripheral biopsy? Mine is about 1.1 and then freeze time about 5 to 6 seconds each.
Same for me.
Dr. Shada?
Yeah, about that. I mean, I start with
Oh,
about 3 seconds, and I'll see the size of tissue that comes out, and I'll go up or down depending on how the first biopsy was.
All right, one more question. What is your experience with the new iris scope for peripheral bronchoscopy biopsy?
I don't have any.
Yeah, I don't have iris scope. So any other in the panels that have explained about iris scope for more than welcome to answer.
Then I also think we are at time.
Yes.
So I think we should hand it over to Mike
Yes.
for introducing the next session.
All right,
Thank you to
very
all the
much,
speakers.
everybody. Thank you.
Thank you all. That concludes our second session of the day, and now we have a 5-minute break. I ask for your attention to this short video from one of our sponsors.
My name is Oliver Wagner. I'm Vice President and Medical Officer at Intuitive. After nearly 30 years as the leader in minimally invasive robotic technology, we released the Ion Endoluminal System in 2019 with the aim to enable physicians to detect lung cancer earlier and more accurately.
The Ion robot has been a huge shift in paradigm for us. And every tool is designed to make my life easier. It allows us to very accurately biopsy. It gives me confidence that I'm going to safely do it.
Ion's new software update builds upon 34 other software updates we've released the last 5 years, keeping pace with the need for innovation in lung cancer interventions.
The Ion system has been a game changer for the world of bronchoscopic lung biopsy.
Ion is allowing me to do more procedures throughout the day.
We listen, we learn, we innovate, transforming lung care now and into the future. We've been focused on improving lung cancer care for over 5 years, constantly capturing feedback, learning from our users, and using those insights to design and innovate with intention, consistently providing updates that generate unique value for our physicians.
Intuitive has continued to put in evolution in the software that has made the ability to get to that lesion, to take that biopsy more efficient, faster, and easier. We can do more procedures in a day, and this has really revolutionized how quickly we can get patients through the door.
One of the things that I love about working with Intuitive is the constant innovation. I think the company really listens to us as physicians. You know, we're the users on the ground.
I believe that all the upgrades have started with the physicians.
My respect for engineering has just tripled, you know, in working with this company, because if you think about it, they can make it happen, and they do. There are so many features, things like preview path and ways to correct for CT to body divergence, even within the system, because it's shape sensing. It's figuring out where you are as you go. And those are features that I use regularly on a day-to-day basis.
We're excited to announce we are releasing 3 groundbreaking innovations for Ion, along with advanced plan point features and a strengthened CBCT integration. My Intuitive is also now available for Ion in addition to other connected features.
As technology advances, you want the equipment that you're using to advance as well. And I think that this platform really echoes that sentiment.
Mobile cone beam integrated with the Ion has truly been a game changer for us. What it has allowed us to do is go after smaller, scarier, more difficult lesions than we ever could before. Our ability to do our 3D spins and our mobile cone beam and integrate it has gotten significantly faster and more accurate. Now, the moment I click through the screens, it's already processed and I can update within seconds. That's amazing.
Having that efficiency allowed me to do the 5th or the 6th procedure in the day.
For lesions that are more challenging, smaller nodules, things that you can't see with radial EBUS, things that are anatomically challenging locations, that's where I think cone beam really shines. You are able to see exactly where your catheter is in space. You're able to see which direction your tools are going in.
That means a high level of confidence to position the tools inside the lesion, knowing that you're collecting sample not blindly in the lung, but exactly where you want it is key.
Reference area-ability has dramatically improved how we target different areas of a lesion and go after it all at the same time.
So I can focus on that area that is the area of interest in the PET scan and target the biopsy to that area. It's more efficient and you just feel more confident.
Let's say I have a larger lesion and there's only one small area of that larger lesion I want to go after, because maybe that's where our PET scan lit up. I can mark both the large lesion and the area of reference I'm really concerned about, and now I know where to target. One of the biggest advantages for network plan transfer is not having to take the USB key from our plan point software to the Ion robot for every single robot.
As soon as you have finished planning your procedure, the procedure is already in your eye and you're ready to go.
If you can save 10 minutes, 20 minutes, 40 minutes per case, then at the end of the day, you've had the ability to add on another case every day. And that really adds up over time.
5 years of innovation, 5 years of technological enhancements, 5 years of software updates, years of proven, meaningful development, offering physicians the platform of the future. We listen, we learn, we innovate with a goal of transforming the future of lung care.
Thank you for your attention. Now I would like to introduce session 3, evolution from access to staging of the mediastinum.
Yeah, hello, welcome from Germany. My name is Kai Darwish, and it's a real pleasure to be part of this interesting and comprehensive webinar. I'd like to introduce my co-chairs, Takahiro Nakajima from Japan and Hideo Sripasad from Thailand. And it's now really a very interesting session we are now going in, because I think this is really one of the biggest success stories we have in interventional pulmonology. So the development of the EBUS procedure. So I first hand over to my co-chair, Takahiro Nakajima.
Hi, good morning, good afternoon, good evening, everyone. And thank you very much for joining this webinar. I'm Dr. Nakajima from Tokyo Medical University in Japan, and Kai and Dr. Sitiwat. Thank you very much. I'm very happy to be able to co-chair with you. And And today it's a very exciting program. We're focusing on mediastinal staging. So I'm very happy to have this session. So could you have some comments, Professor Sri Prasad?
Yes, can you hear me? Thank you very much, and I'm glad to be with all of you. And I think Professor Davish, would you like to start?
Yes, I would like to start, and I would like to introduce Professor Atul Mehta to start with the first presentation, and it's unnecessary to spend any words on that because Atul Mehta is one of the biggest and most experienced among us, and we are very curious to hear your talk, Atul Mehta. Thank you.
Good morning. This is it's around close to 8 o'clock in Cleveland. Can you hear me?
Yes.
Can you see my slides? Can you see my slides?
No, not yet.
Not yet.
Let's see here. Share. I'm sorry. Here. You are sharing. Okay.
Yes,
now,
it's coming.
Can you see my slides now?
Yes, and can you change to a slideshow?
Yeah. Can you see it now?
It's a speaker mode.
Okay, let's see. There's a different way of doing it. Show taskbar display setting. Now?
Yes, perfect.
Okay, can you see the presenter mode?
Yes.
Good morning, good afternoon, good evening. Thank you very much for this opportunity. This is truly an honor for me to participate in this meeting. Last session was related to the robotic bronchoscopy and cone beam CT. So I would like to bring everybody down to the earth level and talk about less of the technologies than what we just heard about. And the topic which has been assigned to me is move over conventional TBNA and mediastinoscopy to endobronchial ultrasound TBNA. I have lots of biases over the years. I have been performing bronchoscopies for over 45 years, but none of my biases are financially driven. In other words, I don't have any conflict of interest. Just last week, one of my colleagues, one of my fellows, published a letter to the editor in Journal of Bronchology. And very elegantly, he said that art of bronchoscopy lies not in how much tissue we can obtain, but in how wisely we apply the tools we have. You know, it is not always getting a bigger piece is necessary in our practice. With that in mind, and talking about EBUS TBNA, why we are saying that there is no need for mediastinoscopy is just looking at the most popular guidelines published by American Thoracic Society and American College of Chest Physicians. And what they say is that EBUS TBNA is recommended as the initial procedure for mediastinal and hilar lymphadenopathy. You reserve the mediastinoscopy for non-diagnostic EBUS or when pretest probability for METs remains very high. Combined EBUS and EUS increases sensitivity for mediastinal staging. So that is what is in most cases sufficient. And the main reason for this is that most of you do perform EUS, esophageal ultrasound. So if you combine EBUS and EUS, you are pretty much completing the entire map of mediastinum except probably station 5 and station 6. So EBUS stations are 2 right and left, 4 right and left, 7, 10 to 13. EUS allows you to sample not only station 8 and 9, but you can also biopsy subdiaphragmatic lesion, such as that involving the adrenal gland and on occasion liver lesions as well. So the combined approach improves sensitivity and reduces the need for surgical staging, in other words, mediastinoscopy. Let's look at the diagnostic yield of EBUS TBNA and compare it with the mediastinoscopy. EBUS TBNA diagnostic yield is as high as 89% across all indications. Mediastinoscopy yield is, of course, higher than that. However, if you combine EBUS and EUS, the pooled sensitivity is close to 95% for mediastinal staging, and therefore first-line EBUS is sufficient for most patients. And we reserve mediastinoscopy for discordant or non-diagnostic cases. I would like to emphasize, however, that EBUS TBNA has got significant fringe benefits. And what I mean by that if there is stage 4 disease, as I just mentioned, paraesophageal lymph nodes, adrenal lymph nodes, you can biopsy them with EBUS TBNA and not with mediastinoscopy. Dr. Yasufuku is now focusing also on station 12 and station 13 lymph nodes, which can, of course, easily be biopsied by new generation EBUS bronchoscopes. Very important aspect of restaging following neoadjuvant therapy, which is much more easier with EBUS TBNA than with the mediastinoscopy. What I call them quasi-central lesions, parenchymal lesions, can also be biopsied with EBUS TBNA and diagnosis can be made. Transvascular needle aspiration can also be performed to diagnose certain cases not approachable by any other means. Of course, I do not recommend biopsying mediastinal cyst with EBUS TBNA, but in cases where required, that could also be carried out. This is what I mean by quasi-central lesions or parenchymal lesions. Dr. Francisco Almeida published a very elegant study a few years ago in Journal of Bronchology to show the utility of convex probe EBUS for visible intrapulmonary lesions. It's a large study. It was, of course, it was a retrospective study, but in 108 patients, his diagnostic yield to diagnose parenchymal lesions with the EBUS scope was 87%, and that cannot be done with mediastinoscopy. Also, as I mentioned to you, you can also use your tool to perform transvascular needle aspiration. It was Dr. Joseph Cecinia from the Cleveland Clinic carried out this study in 10 patients, and he was successful in making the diagnosis in 9 out of these 10 patients without any major complications. And therefore, EBUS TBNA is definitely a superior tool than other tools we are comparing it with. Dr. Bandyopadhyay wrote a very elegant editorial about 10 years ago in Journal of Bronchology, and he said that EBUS TBNA for the diagnosis of lymphoma is still an Achilles heel because the diagnostic yield of EBUS TBNA is close to about 67%. However, in recent years, availability of the cryobiopsy and forceps biopsy has increased the diagnostic yield of EBUS TBNA also for lymphoma patients. So EBUS-guided forceps biopsy and cryobiopsy increases the diagnostic yield, especially for lymphoma, and yield goes as much as up to 90%. And if you just use the EBUS TBNA alone, the yield is about 77%. And it is particularly helpful when the tissue architecture is required, especially in lymphoma and sarcoidosis. Dr. Zhang, in his recent publication, showed a beautiful pictures how to perform forceps biopsy using EBUS scope. They use a laser fiber to put a hole into the tracheobronchial tree to insert their forceps. And as I show you here, the forceps is opening, biopsying the mediastinal lymph node to increase the diagnostic yield of EBUS TBNA or EBUS biopsy. So that is how you can also use EBUS scope for diagnosing lymphoma. And this is a beautiful meta-analysis also by Dr. Yang in recent months, as you see it here. When you use forceps biopsy using the EBUS scope, you improve the odds ratio of making the diagnosis of lymphoma by anywhere between 4 to 91-fold. So therefore, EBUS bronchoscopy or EBUS TBNA is also useful in patients with lymphoma where there were limitations in the past. This is just article a week ago. It was published related to mediastinal restaging in non-small cell carcinoma patients, comparing EBUS TBNA and mediastinal cryobiopsy post-neoadjuvant therapy. All of you will agree with me that mediastinoscopy is a bit hazardous when patient has already undergone radiation therapy and chemotherapy. In this situation, using EBUS TBNA and EBUS cryobiopsy, as you see, the yield is as much as 95% as compared to without cryobiopsy, about 63%. The sample was adequate in 94% of the patients where molecular testing and genetic testing could be carried out on the tissue sample. The rate of non-diagnostic bronchoscopy dropped from 22% to 4.5%, and all EBUS transbronchial biopsies cases were true negative. All negative EBUS transmediastinal biopsy, they were true negative when those patients underwent mediastinoscopy. Once again, proving the point that EBUS TBNA and EBUS cryobiopsy and EBUS biopsy forceps are good for restaging the mediastinum following neoadjuvant therapy. There are significant limitations of surgical mediastinoscopy. Not all thoracic surgeons are that comfortable performing mediastinoscopy due to lack of training in some instances. Also, I see this, I've worked with very many thoracic surgeons, there is lack of standardization in collecting specimens and often in mediastinoscopy. All patients, of course, require general anesthesia. You cannot biopsy station 6 to 13, and on occasion you may require Chamberlain's procedure, and mediastinoscopy is marred with major complications, and we'll spend time on it a little bit. Of course, there are aesthetic issues that patient is left with a scar of mediastinoscopy, and as I just mentioned, that restaging could be challenging with the mediastinoscopy. I agree with you that in recent years, the mediastinoscopy is performed with a video-assisted mediastinal surgery. However, according to the recent data, the complication rate is almost 4%. Of course, this rate improves with experience. However, left recurrent laryngeal nerve trauma is there, and it is more than right recurrent laryngeal nerve trauma, which can lead to vocal cord palsy. There are cases of laceration of the azygous vein. There is history of there are complications of mediastinitis. There could be bleeding from aortic arch. Pneumothorax has been reported. Tracheal and esophageal perforation can also occur even when you use video-assisted mediastinoscope to carry out this procedure. Very recent paper talking about coming from the horse's mouth, the surgeon himself from New York, he's stating that mediastinoscopy is a routine component of thoracic pathology evaluation, but it is less frequently done in the era of less invasive endoscopic alternatives. With an experienced surgeon, mediastinoscopy is relatively safe. However, complications can occur and must be managed quickly to avoid severe morbidity and mortality. Hemorrhage is the most common complication of mediastinoscopy. And don't forget, there are contraindications for mediastinoscopy, that is diminished neck mobility, obesity, large goiters, previous chest radiation, superior vena cava obstruction, superior vena cava syndrome, where EBUS TBNA can be very easily performed as the superior vena cava is pushed away from the trachea and the main bronchi, and anomalous anatomy or congenital conditions. These are some of the contraindications to carry out good mediastinoscopy. Let's talk about cost effectiveness in this era in 2025. EBUS TBNA costs relatively $2,000 less per case than mediastinoscopy. EBUS strategies dominate mediastinoscopy, that you perform EBUS TBNA first for medical mediastinoscopy, and if negative, consider surgical mediastinoscopy. That strategy is more economical than otherwise. EBUS TBNA leads to fewer readmissions, it provides quicker recovery, and it also provides repeatability advantages, as I mentioned, in case if you have to do restaging of the mediastinum after neoadjuvant therapy. So the topic given to me was move over mediastinoscopy, and this has already been shown, as you see from this beautiful graph published from Manchester, that they were performing close to 200 mediastinoscopy in year 2011. Today, they are performing less than 20 mediastinoscopies per year. They are performing more EBUS TBNA as compared to 40-some procedures now to almost 1,600 procedures. So the topic given to me that move over mediastinoscopy has already happened in recent years. So let's briefly talk about what is there in the future related to EBUS TBNA. And I borrowed these slides from my friend Dr. Yasufuku. EBUS TBNA is going to move into artificial intelligence. And the computer itself would tell us if the patient has got malignant or benign lymph node. I'm not very smart to understand every aspect of this artificial intelligence and EBUS TBNA, but by putting the scope next to the lymph node, it will show you whether the lymph node is either malignant or benign, and then you will focus on biopsying this lymph node to confirm what type of pathology you are dealing with. There are different types of systems available, or what you call algorithmic approaches are available with the accuracy of almost 91 to 97%. And this lies in the future, truly pushing the mediastinoscopy far away from our clinical practice. Last two slides on conventional TBNA, I don't think it has got much value at the present time, as conventional TBNA sensitivity is around 50% even in favorable locations, while EBUS TBNA sensitivity is almost 90% with a negative predicted value of 91%, and superiority of EBUS is consistent across all meta-analysis when you compare it with conventional TBNA. I do perform conventional TBNA even today, and that's it's my child. You know, I spent lots of years performing this, so I would say the role of conventional TBNA in 2025 is mainly for diagnosing, especially the small cell carcinoma, in the developing world, diagnosing tuberculosis, and sometimes you can also sample endobronchial disease with the conventional TBNA. You can use this tool to inject drugs into the endobronchial tree. If there is lack of training for EBUS TBNA and there are financial restraints, yes, you can use conventional TBNA. And there are problems with the maintenance of your EBUS scope. Of course, you need to turn back to using conventional TBNA. When I do robotic bronchoscopy or electromagnetic navigation, all the needle aspiration you do, don't forget at the end of the day, all of these is conventional TBNA. So let me summarize what I said in last 15 minutes. EBUS TBNA is the first-line diagnostic tool for mediastinal evaluation, either malignant or benign. Compared with mediastinoscopy, it is safer and economical and is guideline endorsed. Mediastinoscopy is an acceptable option. However, it is rarely needed. Where there is no EBUS TBNA, yes, you can still perform mediastinoscopy. Compared with conventional TBNA, it is clearly superior. Conventional TBNA is of limited value when it comes to lung cancer staging. EUS, cryobiopsy, EBUS forceps biopsy, transvascular needle aspiration are valuable adjunct to EBUS TBNA, and artificial intelligence will take EBUS TBNA to the next level. Thank you very much. I think I'm not able to advance my slides any further, it looks like. Okay, thank you. I appreciate your attendance and listening to me. Thank you. Huh? Okay, I'm sorry.
Thank you very much, Dr. Mehta.
Thank you, sir.
Now move to
any questions?
Let me see.
there's one question is coming from Dr. Talat. His question is, thank you very much for all very nice presentation. What do you think about the future of taking cryobiopsy from mediastinal LAPs under EBUS guidance?
Can you see me? Can you hear me?
Yes. Yes.
Okay, so the question is, what is the future of cryobiopsy performed through EBUS through the EBUS scope? And as I mentioned that, yes, there is a great value of this particular tool. However, as we discussed and as we heard in the prior session, that it is not that every patient requires use of cryoprobe through the EBUS scope. Don't forget the cost. It costs close to $400 per procedure, per use. So we reserve the use of cryoprobe for when we suspect lymphoma or even benign pathology where I need to obtain larger piece of tissue. Again, as I mentioned in my first slide, quoting Prince, who said that it is not the size of the tissue that is important. The person who is looking at the tissue is also very important, in the sense that I hope all of you have got very well-trained pathologists to look at all these tissues we are gathering and the samples we are gathering to make the diagnosis. The short answer is yes, there is a role of cryoprobe while doing EBUS TBNA, where tissue architecture is required and should be maintained, such as in lymphoma, especially with the Hodgkin's disease, when you want to see the Reed-Steinberg giant cells. But it is not required for all the cases, especially that of non-small cell carcinoma or even small cell carcinoma of the lung. I hope I answered your question.
Thank you very much.
Okay, so we will have a question answered at the end of the presentation again. The next session would be Dr. Takahiro Nakajima, and he's from Japan, and he will talk about complete mediastinal staging for lung cancer. Please, Dr. Nakajima.
Thank you very much, Dr. Sriprasad, and I do like to share my slides. Can you see my slides? No, not yet.
Not yet.
I can see your yes.
Yeah, this is.
Oh yes. Okay. Let me try again. Yes, it's coming.
Not yet. Okay.
That's not the presenter mode. Yes.
Yeah.
Okay. Thank you. Thank you very much. So, hello everyone, my friends and my esteemed colleagues. Today's my talk is about a complete mediastinal staging of lung cancer. CUI is as follows. Now that we use the 9th edition of TNM classification, and the most important thing is end descriptions are changed from 8th edition of TNM to the 9th edition of TNM. That we have to divide the N2 disease to N2A and N2B. I mean, N2A disease is a single station N2, and N2B is a multi-station N2. So if you diagnose as a T1N2A, using a 8th edition was a stage 3A, but using a 9th edition, it goes to a stage 2B. It's a very big difference. Because the discussion has been made a long time ago that when they made an 8th edition of TNM, there's a very big difference between the N2A single station and N2B multi-station when they made an 8th edition, previous edition of TNM staging. And they decided to separate the N2A disease and N2B disease for the 9th edition of TNM. And they made a very clear, beautiful survival curve by dividing a single station N2 and multi-station N2 for the 9th edition of TNM classification. But the pathological nodal staging is okay because I'm also a thoracic surgeon in Japan. So I dissect all the lymph nodes, and we usually diagnose the N2A and N2B disease for the patient, but the clinical staging is very difficult. So we have to think about how to differentiate N2A, I mean a single station, from N2B, multi-station in clinical nodal staging. So the answer is the evaluation of multiple mediastinal lymph node is mandatory. From the SCORE study, the target sampling to change to a systematic sampling and EBUS plus EUS. So the plus 9% improvement in sensitivity for detecting N2 and N3 disease. So that it's very important, adding a systematic EBUS and EUS and systematic EBUS plus EUS, the more multi-station N2 disease can be detected. So what I'd like to explain what is a systematic nodal staging. So for example, the patient has a lower lobe lung tumor. We start the observation of the lymph nodes, start with a higher lymph node. The most closer lymph node is 11I, then move to 11S, 10, 7, 4R, and 2R, and 4L, and 2L to 4L, and then contralateral N3 nodes. So then we start evaluation, TBNA for the station, for the N3 node, station 4L, and then station 2L, 2R, 4R, 7, and it goes to very close to the tumor higher lymph node 11S and 11I. That's the systematic nodal staging. So in the ICI treatment era, beyond the mediastinal staging, N1 staging is also very important, and it's also important for the biomarker testing as well as PD-L1 immunohistochemistry. So question is, why is staging important? Because it can be an indicator of resectability. The many thoracic surgeons think of a single N2 disease, N2A disease is potentially resectable, but for the N2B disease, N2 multi-station N2, the less doctors think about it's a resectable disease, and some stage are unresectable disease. So it's very important. Plus, why N1 staging, biomarkers, and PD-L1 immunohistochemistry is important? The answer is because neoadjuvant therapy, the current neoadjuvant, ICI, immune checkpoint inhibitor plus chemotherapy, may offer a chance of cure for the locally advanced disease patients. Looking at the JTO, the consensus recommendations for the stage 2 disease, neoadjuvant chemoimmunotherapy is preferred, and for the stage 3 disease, neoadjuvant chemoimmunotherapy is strongly preferred. And also, if the patient harboring EGFR gene alteration or ALK alterations, the immunotherapy is not recommended. So the staging is very important. However, the radiology, the sensitivity and specificity, the diagnostic yield is not satisfactory. So the minimally invasive or invasive method is recommended for the mediastinal staging. Professor Mehta explained about the diagnostic yield of each modality, and EBUS TBNA and EUS FNA shows a very good sensitivity as well as specificity. And combination of EUS plus EBUS shows a very high sensitivity, 91%, and very, very high specificity of 100%. So looking at the several guidelines for the mediastinal staging of non-small cell lung cancers, many guidelines said the patient should undergo pathological nodal staging if the patient have a lymph node short axis more than 10 mm on CT, or FDG uptake on PET scan, or a suspected CN1 or higher disease, and if the patient have a central lung cancer or the tumor size is more than 3 cm, the pathological nodal staging is strongly recommended. So today, I want to show two cases of, this is actually a very recent case of staging. I performed for these cases. The first case is a 70-year-old male, and he has a right upper lobe lung tumor, and it has already diagnosed as squamous cell carcinoma by bronchoscopy at previous hospital. And EBUS at previous hospital, it was a target sampling. The station 7 was negative. The FDG PET shows the SUV max primary site was 13.67 and right Highland was 21.75. And CDX, the biomarker testing was negative, and PD-L1 immunohistochemistry was 85% positive. So my question is, what is the end staging in this case? This is a station 2R. The short axis is 3 millimeter, very small. This is a station 4R, 12 by 7 millimeter. Station 7 is also not so enlarged, 13 by 7 millimeter, but FDG showed a slight uptake on the station 7. Station 11S is enlarged and very high accumulation on PET scan. So what is the diagnosis of nodal staging of this patient? N1, N2A, N2B, or N3? So I started evaluation from the N3 nodes, but there's no lymph node visualized at station 4L, so I skipped sampling for 4L. So the station 2R, it was 9.8 by 6.7 millimeter, so it was negative. And next was the station 4R. It was actually less than 10 millimeter in short axis on the EBUS image, but it was positive. And the station 7, actually it was positive. So the patient was diagnosed as N2B disease, and now the patient is undergo checkmate 816 regimen. The total procedure time was 30 minutes, and the patient was performed this procedure with a local anesthesia with mild conscious sedation. So this is a second case. This is how to assess N2 stations. The second case is a 70-year-old male. He has a left upper lobe lung tumor, and primary lesion has not been diagnosed and has not been biopsied yet. And FDG PET shows a primary site was 14.94, and left mediastinum lymph node was 9.24. So my question is, what is the nodal staging in this case, and how to assess N2 stations? This is a station 2R, it's small. Station 4R is 13 by 7 millimeter. Station 7, 9 by 5 millimeter. Station 2L is also very small, 3 millimeter, no accumulation on PET scan. Station 4L, 8 by 5 millimeter, but there's a slight accumulation on FDG. Station 5, the station 5 cannot be always assessed by EBUS or EUS, but some selected cases we can assess the station 5 from the esophagus approach, I mean EUS. It was a 16.10 millimeter and very high abnormal accumulation on PET scan. So what is the staging N1, N2A, and N2B or N3 of this case, and how do you assess these lymph nodes? So I want to show a video clip. I start checking this from the station 2R. Here's the station 2R. On EBUS image, the short axis is less than 5 millimeter. It was actually 3.6 millimeter, so I skipped evaluating the station 2R. Next station was a station 4R. The size was 12.8 by 7.0 millimeter on EBUS image, so I decided to perform TBNA for this station 4R. Elastography shows a partially blue and TBNA. So I decided to perform, if I can obtain a core material, I puncture the twice, 2 times for each lymph node. So I could obtain a histological core. So I made a TBNA for 2 times. Next is a station 7. It was negative. Here's a station 7. The size was 9.2 by 7.0 millimeters, so I decided to perform TBNA. Elastography is a green predominant. It's a soft lymph node. So TBNA, this is our first time. Another pass, the second time TBNA. So also there's a histological core and a rapid on-site evaluation, so the negative for metastasis. Next station is a station 4L. It's enlarged. The size was 11.6 millimeter. And also a high vascular flow. Elastography was shown. Part blue finding. And I performed the TBNA twice. I could obtain a histological core as well. And it was positive on rapid on-site evaluation. Then I pull back the scope to the aura, then insert the esophagus again, and I evaluated the station 5. It's a EUSB FNA procedure, transesophageal approach. It was positive for metastasis. So I punctured 4 stations by EBUS TBNA as well as EUSB FNA. So I reviewed that this patient has an N2B disease, and that now the patient underwent a Keynote 671 regimen, and the total procedure time was 42 minutes. So today's key points. TNM 9th edition requires distinction between CN2 and CN2B, and accurate CN staging needs systematic sampling and consideration of the EUS approach. And biomarker testing and PD-L1 should be performed simultaneously. I mean, it is a real complete mediastinal staging, and with the advent of effective therapies, precise nodal staging has become increasingly important. To provide optimal lung cancer care, and let's lead patients to cure. Thank you very much for your attention.
There's one question. No, there's no. There was one question addressing if you change the needle between stations, if you have N2 stations. So maybe you can address this question, Takahiro.
Yes, If the rapid on-site evaluation was negative, I using the same lymph node, same dedicated TBNA needle. If the rapid on-site evaluation was positive, and when I needed to evaluate the additional lymph node, I change the needle to the new one to avoid the contamination.
Okay. Another question. When do you use transbronchial mediastinal cryobiopsy and when TBNA? So another question to the cryobiopsy.
Sorry, in Japan, we cannot use the EBUS guided cryobiopsy, so I haven't experienced yet.
Okay.
But the answer
Okay,
is the same as Professor Mehta.
Yeah. Okay, then we come now to the third speaker, and this is Dr. Titiwat Sriprasad from Thailand, and about molecular diagnostic area. So please.
Thank you very much. Can you see my slide?
Yes.
Okay. Thank you. And thank you, Dr. Ping Li, for invitation to have me talk about this topic. And my topic is a molecular diagnostic era, how to optimize with the needle versus cryotherapy. I have no disclosure related to this talk. These are the important biomarkers. And as you can see that there are many biomarkers that has the targeted treatment. So it's important for us to recognize and send the test and the appropriate test for the further treatment for the patient. But it's not just only to method of retrieving the tissue, but to get the adequacy of the sample, it depends on the test that we want to send to, and also the sensitivity of the method to test that. Also the type of the tissue, laboratory expertise, and the time of tissue processing. As we know that the longer time the DNA become less and difficult to get test. These are the sample of the adequacy criteria. For example, we at least need the tumor cell count more than 100 viable tumor cells, neoplastic cell percentage mostly 20 to 30%, and the surface area more than 1 square millimeter for NGS testing. These are the example. For example, EGFR mutation, we need at least a tumor ratio of 30% or more with 100 tumor cells. The ALK at least 50 tumor cells. PD-L1 at least 100 tumor cells. And for NGS with the Oncomine testing, then the tissue surface area of the tumor must more than 1 square millimeter, and the tumor content ratio more than 30%. Now I'm going to talk about TBNA. This is the meta-analysis of the TBNA, and that evaluate the NGS testing. And this includes 21 studies, and the full adequacy of the TBNA for NGS testing is 86%, and it range from 80 to 91%. Oh, sorry. And this graph shows that the prop DNA extract from the EBUS TBNA, and usually the average DNA extract is 860 nanograms, which is adequate. For the NGS testing, the average NGS testing DNA is around 100 nanograms, and usually some tests require up to 500 nanograms of DNA testing. So with the EBUS TBNA from this study, it's adequate for NGS testing. Now, the factor that influence the NGS testing from this study is the number of pass. As you can see that the less number of pass, the less tissue and then inadequate tissue that we get. So in this study, if we perform 5 or 6 passes, the chance that we get adequate tissue sampling for for NGS testing is higher, especially with the 6 passes. The chance to get the sampling successful NGS testing is 95%. Now I'm going to talk about the PDL1, and this is the retrospective study of 263 specimens for PDL1. And as you can see that usually half of them they're sampling only 1 or 2 stations, and half of them they're sampling 3 or more stations. In this study, the squamous cell carcinoma and adenocarcinoma, most of the time we get sufficient for PDL1 testing. But when we look at adenocarcinoma itself, the subcarinal lymph node tend to have a higher PDL1 testing compared to other locations. And also in adenocarcinoma, the size of the lymph node also important. The bigger size also has a higher diagnostic view. Now I'm going to talk about the ROS. For TBNA, the ROS does not increase diagnostic view, as we all know, but with the ROS, we can evaluate the adequacy of the tissue. Especially, this is quite study that more than 10 years ago that evaluate 85 patients and all with ROS. 81 out of 85 is adequate for molecular profiling. In this study, basically KRAS, EGFR, and EML4-ALK. And in this study, they do only 4 passes per location, and they can get up to 95% of molecular profiling. As you can see that the ROS is important. It does not increase diagnostic view, but it also helps us in terms of evaluation of the adequacy of tissue and direct feedback to the operator, whether to change the method or change the needle to improve adequacy of the tissue for molecular testing. Now, I'm going to talk about the needle itself. This is a study comparing 19 gauge and 21 and 22 gauge needle. As you can see that the amount of DNA extract from 19 gauge needle is higher than 22 gauge needle, but it does not reach the statistical significance. In terms of NGS testing, the 19 gauge needle and 22 gauge needle, no significant difference in terms of successful NGS testing. The 19 gauge needle provides higher and larger tumor surface area, but compared to the 22 gauge needle, but it does not reach statistical significance. So the needle is actually does not matter in terms of molecular testing. In our institution, our fellow did the study comparing the EBUS TBNA and also EBUS forceps biopsy, mini forceps biopsy. And we see that the EBUS TBNA itself provides total tumor cell count more than 1,000 cells in more cases compared to the EBUS forceps. And that reached statistical significance. And the tumor cell percentage is actually higher in EBUS TBNA comparing to the EBUS forceps. But in this study, it does not reach statistical significance. So I'm going to talk about the cryo. I think most of everyone already know that the cryo itself is actually this is a randomized control trial comparing the cryo biopsy and standard EBUS TBNA. And you can see that in lung cancer, the diagnostic view does not differ between 2 methods, but in lymphoma and benign tumor, the diagnostic view is higher in EBUS TBNA. I'm sorry, in cryo biopsy. And this meta-analysis showed that that include 2 RCT with the case history and prospective, showed that it favor cryobiopsy comparing to the EBUS TBNA. But if we look at the lung cancer itself, the full diagnostic view does not differ. This is another meta-analysis that include 1 RCT and the rest is prospective and case series, showed favor of EBUS cryobiopsy comparing to the EBUS TBNA. But if we look at the subgroup analysis of the lung cancer itself, the EBUS cryo provide diagnostic view around 94% compared to 93% of EBUS TBNA. So basically in lung cancer, it does not different in terms of diagnostic view. So where is the cryo stand in the diagnostic? If we look at this study, the cryo itself usually provide better tissue and your pathologist usually happy with this cryo because of the preservation of the histology and the beautiful tissue. And in this study, it showed that NGS can be reached up to 95% in cryobiopsy using 1.1 cryoprobe. And this is a study from Dr. Ian Su in Malaysia. They retrospectively review 104 cryobiopsy compared to 99 cases of TBNA. The yield in cryo is 90% compared to TBNA is 67%, which is lower. And in this study, it's a little bit lower than previous study that I present. And overall, higher tumor cellularity, 65% compared to 30% in TBNA group, and higher NGS successful testing, 85% compared to 61%, and those with statistical significance. In this study, most of the cases they did the 4 passes of TBNA and also 4 passes of cryo. The complication does not differ between 2 groups. And if we look at just the diagnostic view of lung cancer, common tumor, non-small cell and small cell, the cryo and the TBNA is not that statistical significant. So the yield is actually increased from the uncommon tumor and most of the time. But if we look at the tumor cell count and tumor cell content, the TBNA provide less tumor cell count and less tumor cell content compared to the cryo. And that reflects to the NGS testing that require higher tumor cell count and higher tumor surface area, for example. So in this study, the NGS is higher in cryo group. But interestingly, the EGFR mutation and limit panel molecular testing is higher in TBNA group. Overall, there is no difference between heterogeneous and non-heterogeneous region. The question comes, how do we perform cryobiopsy? And this is a study that shows how do we perform, how should we provide the evidence of the performing cryobiopsy. That includes 129 EBUS cryobiopsy and diagnostic view is 88%. As you can see that the size more than 4 millimeters and above does not show significant in terms of a diagnostic view, but less than 4 millimeters, it provides less diagnostic view significantly. The number of cryo passes, 2 or 3 passes is adequate. Above of that, we will not be able to get the higher diagnostic view, but 1 pass is less, significantly provide less diagnostic view. And then look at the freezing time, the 3, 4, or 5 seconds does not show significant in terms of diagnostic view. So basically this study from Dr. Ko provide us the evidence of how to perform the cryobiopsy. And we did the cryobiopsy in our study, and usually freezing time is around 4 to 5 seconds, and we usually get 4 to 5 millimeter sample for molecular diagnostics. In conclusion, I think the needle and the cryo is the art of the sample. The TBNA itself is more familiar. It provides adequate for diagnosis of lung cancer. It's adequate for limited molecular tests. If you want to do NGS, you probably need more passes, especially 6 passes to reach the diagnostic test of 95% in meta-analysis. Obviously, we need the cell block, not the cytology. And ROS is important to provide adequate tissue feedback and for NGS. And if we don't get the adequate tissue, then we need to change the method of getting samples. The cryo itself is less familiar. Data show that it's safe, it's non-inferior for lung cancer diagnostic, and it's better for uncommon and benign disease. It provides more tumor cellularity, and especially for NGS testing. But those studies compared to 4 parts of TBNA, as we all know that 4 parts of TBNA, the NGS testing success rate is dropped compared to the 6 passes. And no RCT that look for NGS testing between TBNA and cryo. And I think the TBNA itself is better for the repeated or restaging biopsy, as we know that the TBNA is less provide less diagnostic view. So the cryo itself should be alternative for the repeated biopsy and restaging. And the question comes, should we do both? And that increase the cost and time. And I think that is need further investigation. And thank you very much.
Okay, thank you, Dr. Shipasat, for your view on that. We are behind schedule, so we have to take a look at the time. There's one question, short answer, please. For EBUS cryobiopsy, is minimum size of the lymph node 10 millimeters? Can it be done in smaller lymph nodes?
Yes, the answer said yes. You can do the lymph node at 1 centimeter or 10 millimeter, but it will be difficult. But it can be done. The freezing time is not different, so you can use the 3 or 4 seconds to get the adequate tissue.
So I think most importantly is to see the cryo probe inside the lymph node, then it can be done even in smaller nodes. Okay, thank you again. So we go further, and now we'll come to a great pleasure for me to introduce Wilfried Eberhard. Worked a long time together in Essen. So thank you for your presentation.
Yes, Kai, thanks a lot for giving me the opportunity to speak to you today. This is my presentation. Wait a minute. There it is. Now, we heard a lot about the mediastinal staging, and I think the interventional bronchology is an important tool now that is a basic, together with nuclear medicine and with pathology, to help us in the interdisciplinary approaches to lung cancer, especially in locally advanced disease. Now, these are my disclosures. But what I will not talk about here are new drugs in this setting today. So the question is, we heard about N2, but there are also issues now, and that is the big opportunity for interventional bronchology with EBUS, and with the new techniques you extensively talked about in the last hour, that if confirmed N1 by EBUS and pathology versus N0, this has significant implications on the prognosis of T1, T2, and T3, especially in downstaging. And if you have confirmed N1 by EBUS and pathology versus N2A, that has also significant implications for the prognosis for T1, T2, and T4 upstaging. And we've seen the nice pictures from the last ninth edition, and also the changes that have been implemented. I think that is of major importance. These were presented in last year by the multiple staging papers, and especially one by Rami Porter. And this is another issue that will come up. We heard about the difference now between N2A and N2B, so one lymph node station versus multiple. Now the same could be true at some time point for CN1. So I will come back to this in the end. Now this is a case. I will talk about one case. This is a 71-year-old male patient. He showed up with a tumor in left upper lobe, and these are the diagnostic CTs, and a lymph node left hilar. He had non-small cell lung cancer, and it was an adenocarcinoma. So the tumor was about 2 centimeters, T1B, N1, and this is stage 2A. Now, these are the other data we have for the patient, or we had for the patient, for the discussion of the treatment design. He was TTF1 negative as an adenocarcinoma, so important. He was PDL1 0 in the immunohistochemistry. He did not have any targetable mutation in the NGS, and in Germany, the NNGM analysis, which is the quality assurance NGS by the pathologist. And he was a smoker, 27 pack years. But he had some comorbidities of importance. He had an aneurysma of the aortic aorta ascendens. He had a tear head a few months ago. He had a plaque in the carotis interna left side. And he had risk factors, hypercholesterolemia, arterial hypertension. And he also had tinnitus and partial hearing loss. So there were some vascular risk for chemotherapy, an important issue for the medical oncologist, and I'm one of those guys. So in the multidisciplinary chest tumor board, which was of importance, everybody sitting there discussing, it was discussed that the strategy in this patient would be induction chemoimmunotherapy, followed by upper lobe resection. Now, there were no issues about letting him go to surgery. Now, from the treatment, from us as a medical oncologist, TTF1 negative patients, they are not good for pemetrexed. So there's a discussion against pemetrexed. PDL1 0, we would tend more to induction, not to adjuvant, because after induction, we would see what is the effect also of immunotherapy in the induction. So formal contraindication to checkpoint inhibitors, there were none for the CPI. And this is of importance, the patient didn't want cisplatin due to the hearing loss and tinnitus. And we still stick to cisplatin in a lot of the patients. But in these patients, due to his hearing loss and tinnitus, he definitely didn't want to have cisplatin. So carboplatin was chosen. And we chose a combination of carboplatin, paclitaxel, and pembrolizumab. And this is because the taxanes are most effective in those patients with TTFR negative. Now, the treatment was 4 cycles chemoimmunotherapy, induction with good response and no major complication. And the reason for the 4 cycles was that treatment was very well, and we had a carboplatin treatment, so sometimes we go into 4 cycles. And now he is planned for thoracotomy and upper lobe resection in 3 or 4 weeks' time. He now has just received the 4th cycle. And following the final pathology after PCR or major response, major pathological MPR, major pathological response, we will have a decision about further CPI or stop the the CPI consolidation. So as you can see, this is of importance here. We completely plan our treatment, our multidisciplinary treatment here with medical oncology and with surgery based on your expertise and data. Now, this is about the future, the 10th ISLC UACC staging classification. And we just had a meeting of the staging committee in Barcelona. We will try to look into the possibility to establish N1A and N1B with different survival prognosis. Now, in the literature, there is data that one single N1 lymph node is better than multiple ones. But we will have to see in the future. It'll take some time. You know that this usually takes about 6 to 8 years. And so my conclusion here would be differentiating N1 from either N2, N0 or N2 helps significantly in deciding the further treatment strategy on an individualized, risk-adapted way. So this is my case.
Okay, Wilfried. Thank you again for your really excellent talk and giving your perspective and an outlook to the next. We are struggling with the ninth version, and now you're looking for the 10th. Would be even more complicated to use in clinical practice. Okay, I would move over with my little talk. So can you see my slides? Okay, so I was asked to give a personal view and how do I do EBUS and mediastinal staging, and I think I can make it quite short. So these are my conflicts of interest, and we already talked a bit about EBUS guided cryobiopsy, and it usually comes in many publications. There is a need or an indication specifically in cases of uncommon tumors and lymphoma. So that is nice, but what is exact the meaning of that? So when do you know? What is a clinical situation where you think you might use EBUS cryo? So my personal, and this is very personal, has never been looked. There's no randomized controlled trial on doing EBUS guided cryobiopsy in the clinical situation, so from the clinical appearance. So I have 3 situations where I use EBUS cryo. First, if you have a malignant appearance lesion and a low risk for lung cancer, young age, no smoking, and only mediastinal or hilar lesion and no pulmonary lesion. So I think that is where you can consider EBUS guided cryobiopsy. Second, if you already have done EBUS TBNA and was negative, but still have a malignant apparent lesion, EBUS PET positivity or enlarged in CT scan, so you might consider lymphoma or might consider any rare infectious diseases. So in that situation, cryobiopsy can be considered as well. And the third is if you have a clinically high symptomatic lung cancer stage 4, and this depends on the situation at your center and the availability of rows. So if you need or you have to avoid a second procedure because of having not diagnosed the tumor in the first procedure, then you might consider using cryobiopsy as well. However, this is not really proven into the studies, but sometimes, EBUS TBNA is not 100%, and if there's a clinical need, you might consider taking cryo as well. So this is the clinic. So two cases or 2 examples on the left side. Both cases are from the last week. Left side is a 36-year-old male with having a lymph node enhancement in the PET scan, lymph node station 12 on the left side, only. There were 2 bone lesions, but no pulmonary lesion, and cryobiopsy revealed histiocytosis. And the other was done yesterday, 77-year-old female patient with PET positive lymph nodes, station 7, 11R, and 4R, but no pulmonary lesion. So we considered maybe lymphoma, but we don't have the full histologic report yet, but maybe it looks more infectious diseases. So we have for the results. So this is clinical cases where I consider to use cryobiopsy. The question is how to create the tunnel, and this is the most difficult part of doing a cryoprobe. So there are different techniques described in the literature. I sometimes use and have the opportunity to use the old rigid needle. This is quite helpful in such a situation. However, this needle is not longer produced. So sometimes I use it, but it's not good for hilar biopsy, or not using it for hilar, for example. I'm using it for station 7 and sometimes for 4R, but not on 4L. Most of the time I use the EBUS TBNA needle. I can use a 19 gauge needle. This is quite efficient and rapid and works in almost all situations. Or I use the 22 gauge needle and do a repeated puncturing to create a tunnel. And the experience is, if you had obtained the first biopsy, the second and third biopsy is even more easier to be obtained. The second step is then how to find the tunnel entrance. So I use a mixture and looking on the EBUS image and using on the visual image. Most of the time it's quite easy to find the tunnel entrance and advance your cryoprobe there. And most importantly, and this is regarding safety, the most important thing, that you have to see the cryoprobe in your EBUS image to confirm the correct positioning of the probe within the lymph node and avoiding vessels inside the lymph node. Don't obtain a biopsy if you're not 100% sure that you're seeing your cryoprobe within your EBUS image in the lymph node. And how many biopsies? We already heard this publication from Dr. Ko. So 2 to 3 cryo probes and 3 to 4 seconds of freezing is the best way or sufficient to have your cryoprobe, your cryobiopsy. And the second question was, how do I do complete mediastinal staging? And I focus on, if I do EUS-B or consider EUS-B necessary for complete mediastinal staging or not. We have already seen this slide or the study, so showing us that there is an added value of EUS-B, and this is about 10% added value of adding EUS-B to EBUS. But now we have more data, and this is the Japanese study from Oki, and it was a prospective randomized controlled style comparing EBUS alone versus EBUS plus EUS-B for mediastinal staging in more than 200 cases, and there were no significant difference. So it is obvious that there's maybe not necessary to perform EUS-B in all cases. So in that study, there was an additional value of EUS-B in only 2 patients, and there was lymph node stations that cannot be reached by EBUS, so lymph node station 8 and 5. So what does it mean for our clinical everyday practice? We can summarize, or that is at least my personal consequence on this. So I do ESB not in every patient, but in case of paraesophageal lesions, which can be seen on CT or PET scan, or if you have suspicious lesion station 5, which cannot be reached by ESB alone, and in case of subdiaphragmal lesions, so left adrenal gland and liver. And for the latter, left adrenal gland can be reached in almost all cases. We have studied that and have seen that in almost 90%, left adrenal gland can be reached and can be punctured safely. So we have tested in more than 300 patients and there were no complications. And there's a significant rate of left adrenal gland metastasis in lung cancer, at least in our cohort, was up to 9%. So it is recommendable to take a look on the left adrenal gland, and if there's a PET positivity or it's unclear on the PET scan, it can be easily accomplished to obtain fine needle aspiration from the left adrenal gland. And the last case was a 63-year-old male patient having lung cancer in the left upper lobe, and this primary was very difficult to reach, and even the lymph nodes were difficult to reach, but he has an image of maybe having liver metastasis, so this is a good indication for doing ESB as well. In this case, the liver metastasis was on the left liver lobe and can be reached with ESB, FNA, and confirmed large cell neuroendocrine carcinoma. So to conclude, systematic ESB is not necessary for complete mediastinal staging in every patient, but ESB improves your diagnostic possibilities significantly and should be of your armamentarium of every EBUS bronchoscopist. Everybody who is doing EBUS bronchoscopy should learn ESB, and ESB should become part of our EBUS training as well. So thank you. So I think we move over to the question. So there are some questions coming in.
Professor Ping, can you comment on the anesthesia, LMA or intubated for EBUS cryobiopsy?
Yeah, so I've only experienced to do EBUS cryo in general anesthetic patients, so we are not doing it on local anesthesia.
So Kai, my personal question, can I ask you about EBUS cryobiopsy or EUSB cryobiopsy as well? I'm sometimes worried about seeding of tumor cells to the bronchial wall or esophageal wall, because cryobiopsy is just freezing the tumor cells, and there's a possibility of still contains a viable tumor cells, and that's the big needle or biopsy material pass through the airway, the trachea or bronchus or esophagus. So I think there's a still potential risk of seeding or implantation of tumor cells to the airway or esophagus. What do you think?
Was the question of to ESB or ESB cryo?
Cryo, EBUS cryo or EUS cryo.
Yeah, good questions. So EBUS cryo is available only for very few times. So I think we have to take a close look to that. And we cannot really be 100% sure that it can be excluded seeding. We can say the safety is good, results are good, but we have to get more experience in the future, of course. And regarding ESB cryo, there are few studies showing that it might be possible, but I have even more skepticism in performing that. And this is the seeding. You might lose your cryo specimen outside the esophagus or something. And I think the risk of performing a fistula is not, it's a risk. We know we are struggling with patients having esophageal fistula, and I'm not, I don't want to create some, so I'm very conservative and not performing ESB cryo in the moment.
Thank you very much.
So, to answer Dr. Ping Li's question about the cryo, actually we perform most of the cryo with the moderate sedation. Maybe because of our patients, they're kind of like sensitive to sedation with just a small dose of sedation, they completely sleep. So that's why we perform the cryo mediastinal lymph node with the moderate sedation. We have more questions, but I think we run out of time. So yeah,
I will answer the question in the chat.
yeah, okay.
Thank you, team. Thank you, session 3. That concludes session 3. Now I would like to introduce session 4, adequacy of bronchoscopic biopsy, with chairs Professor Semra Bilasoglu from Turkey and Professor Bing Lam from Hong Kong. If you do us the honors.
Thank you, Michael. Can you hear me? Good evening, ladies and gentlemen. I'm Bing Lam from Hong Kong. I have the pleasure to co-chair this session with Professor Bilasoglu from Turkey.
Okay, good pronunciation.
Thank you.
Okay.
Yes, please introduce.
Okay. I'm happy that I have you as the co-chair. Sorry, I heard that you wouldn't join this meeting because you had an excuse. And they told me that Gregor Velechti will be the chair and the first speaker. Are you the first speaker?
No, I'm not actually, Gregor.
Okay, just the co-chair. Okay, thank you. So, dear colleagues and friends, welcome to this session on adequacy of bronchoscopic biopsy. I and Dr. Tell Me Your Name Bing Lam will chair this session. Our two distinguished speakers are from Golnik, Slovenia. Dr. Gregor Velechti, am I correct in pronunciation?
It's okay. It's okay.
Velechti, okay. And Dr. Alej Rozman, who is a longtime friend and colleague. Hello. And without losing time, I want to introduce the first speaker. Maybe you share the screen in this time, and I will introduce you briefly. Our first speaker, Gregor Velechti,
It's okay. Don't worry. It's okay.
Will talk on what does it mean by adequate. He is a dedicated pathologist experienced in neoplastic and non-neoplastic thoracic pathology in University Clinic Golnik, Slovenia. He's an expert in pathology of lung cancer, mesothelioma, and thymic diseases. His research is focused on subtyping and molecular analysis of lung cancer and mesothelioma, and he organizes and lectures frequently in international meetings and workshops. The podium and the microphone is yours, Dr. Gregor. We are listening to you.
Do you see the presentation? Do you hear me?
Yes.
Okay, the presentation is, okay, you can see it. Okay, so the question is, what is adequate from, of course, the point of view of a pathologist? So first of all, some definitions. What do we mean when we say adequate? Well, if you see, if you look it up in the dictionary, there are several definitions that are quite similar, but I like the third one because it, I think, illustrates our everyday problem. So adequate, actually, it's of a quality that is acceptable, but not better than acceptable. And many times that's the case, especially nowadays when we need to do more and more tests. The importance of a good quality specimen, it's more and more important. So, and on the other hand, it depends on the setting. So, of course, adequate has one meaning when we're talking about immunohistochemistry, and it's different when we talk about NGS or cytology. So, the first step for us as pathologists is, of course, to come up with a diagnosis with the material that we get from you. We get, of course, bronchial biopsies, transbronchial biopsies, CT-guided needle biopsies, and cytology as well. All of these samples, if they are good enough, of course, can be used to do the whole diagnostic workup for a patient. But maybe it's a bit counterintuitive. Size matters, but it's not the only thing that matters. So we can have sometimes just one piece can be enough if it's good, if it's full of tumor cells, and maybe sometimes 10 pieces will not be enough. So more than size, quality is important. So what's in the sample? Do we have any tumor? What's the percentage of the tumor, the number of cells? Is there any necrosis, inflammation that can decrease the tumor content? And of course, the pre-analytical phase, which is very important, especially when we get outside samples, so fixation time, transport, and so on. And here we have a classical situation, a sample from our institution that maybe seems not that big, but when you look at the microscope, there are some pieces of tissue with enough tumor cells to do the whole diagnostic workup. On the other hand, sometimes you can have big chunks of tissue that one would think, of course, that must be enough, but actually, under the microscope, most of the tissue is made up of granulation tissue and inflammation, and only the small encircled part is actually tumor, which means that this kind of sample is not useful to do, not even diagnosis, and of course, not all the other predictive biomarkers that we have to do nowadays. So it's actually an eye test. The pathologist with expertise has to decide without counting, without any high-tech stuff, whether what he sees in the biopsy will be good enough to proceed. First with the diagnosis, morphological, then immunohistochemistry, and so on. So for immunohistochemistry as well, no clearly defined criteria. Usually there's enough at least for TTF1 and P40. If we need to do other markers, sometimes, as I said before, you know, something that is adequate doesn't mean it's actually great, and maybe for the fifth marker, there is not enough tissue. So, you know, again, can be sometimes tricky. But when we come to predictive biomarker testing, which is the most important part of course, of our job nowadays, after we establish the diagnosis, that's where we really have to be very careful with the tissue and spare the tissue. That's why it's important to have one-step approach that nowadays I think most labs, at least in Europe, use. So, so that you do for immunohistochemistry, PD-L1, 2 slides, and then in the same session, all the slides you need for molecular testing, so we don't waste any tissue in between. And this is the first time actually where a pathologist has to produce a number. So we have to say for NGS, PD-L1, and other predictive biomarkers, how much tumor there is in the specimen. So what we have to do is to come up with a number looking at the ratio of vital tumor cells against all the nucleated cells. So we have to discard erythrocytes, fibrin, necrosis, hypocellular fibrotic tissue, and so on. When you have a lot of lymphocytes, then the number, of course, can decrease because of the so many nucleated cells. And again, we don't have any particular tool. It's an eye test. We try to, we have trainings. We try to be as good as possible, but that inevitably leads to great inter-observer and inter-observer variability with a lot of overestimation. And so I think there is a big role for AI maybe in the future to help us be better in this field. And this is a clear example. You have a needle biopsy on the left, which is very cellular, but most of the cells are actually inflammatory, if you see in the higher power in the middle, and fibroblasts, so not a lot of tumor. And so even if you have a couple of tumor islands, that will not be enough. On the other hand, the last part, you see only fibrosis, so the same amount of tumor here can be enough to actually do NGS. And there was a study in Japan where they tried to see how well pathologists could, assess the tumor content. And as you can see, before training, after training, in some cases you have in the red boxes the range. One pathologist said 15% tumor content, and the other one for the same sample 100. So even after training, you see that the range still is quite big in some extreme cases, like from 20 to 90. So we are not as good as we'd like to be in this situation. So how do we assess how do we say whether it's an adequate sample? As I said, we try to be as good as possible by trying to see how many tumor cells we have. So here we have a concrete practical case where the central part is all tumor, and one would say, oh, there's a lot of tumor cells and only surrounding some parenchyma, so it must be at least 50%. But then when we do NGS and you see the results and you multiply the allele frequency by 2, you get the real percentage, which is in this case lower. So what we have right now is just training and expertise to try to be as good as possible. So what are the real numbers? We'll get to that now. The predictive biomarkers we have to do, we have the current biomarkers and then the emerging ones. So the number we have to do is getting greater and greater. So even more tissue is needed. And what are these numbers? For multi-gene panel biomarker testing, especially NGS, for DNA, RNA, which is something that we do routinely, the tumor content is at least 20%. We will try to do sometimes even 10%, knowing that the variability and the overestimation that can be done from our side. And then we'll see if you get a driver mutation, maybe we'll be confident enough to sign it out. If we get a result that is negative on 10% tumor content, then we'll just say, the tumor content was low. Maybe it's good to rebiopsy and try to do it again. For DNA, we need 200 to 500 tumor cells, depending whether we have cytology, specimen, or histology. For RNA, even more, so up to 1,000 tumor cells. For some other single biomarker testing like PCR or Sanger, different percentages. But nowadays, I think most labs try to use NGS because it decreases the sequencing cost per multiple genes. It's more sensitive. And what's most important for us, an oncologist, we get a better picture of the tumor heterogeneity, especially in rebiopsy. We can easily find not only the classical, maybe resistant mutations, but even other mutation mechanisms. For PD-L1, this is immunohistochemistry based, so maybe it's for us pathologists easier, it's more common. We need to have 2 slides for test and negative control, and always a positive control for every run, so we can actually trust the result. And we need to have, the criterion is 100 tumor cells, viable tumor cells, so no necrosis for interpretation. Cytology, on the other hand, can be very useful, and we use it routinely as well, especially pleural effusion and TBNAs. For pleural effusion, there are some criteria, but it's not that strict. The recommended volume is more than 50 milliliters, in some papers even more, 75 or 100. But it's not a strict criterion volume, because we can have positive results even in less, in lower volumes. So actually, all the volume that you pump out should be submitted every time. But even if it's less than 50, of course, we do the cytological examination, and many times it can be positive and used for all the diagnostic workup. For TBNAs, we like to see rows when it's possible. So rapid on-site evaluation we think is very important because it improves the diagnostic yield, decreases the need for repetition, shortens the diagnostic workup, and we can use then the sample to give a preliminary diagnosis and to triage the specimen. So the main goal of it, of course, it's to say whether it's adequate, but the better the sample, the more we can say. So maybe sometimes we can say at least a preliminary diagnosis. So is it neoplastic or non-neoplastic? And of course, we can triage the specimen for other ancillary studies. So from our point of view as pathologists, whether you do blind or ultrasound guided sampling, we like to see some more aspirations with fine needle. We'd like to see a minute sample. So for rows, only one drop and then the smear, and to use the most of the specimen. So that's in the needle. So to rinse the needle very well, because that's what we can use then to do cytospins. And so from that on, immunocytochemistry, flow cytometry, molecular testing, and so on. So to conclude, adequacy actually it actually lies in the hands of the bronchoscopists. From our point of view, tissue is always the issue, but size does not always equal quality. Unfortunately, from a certain point of view, of course, we need more and more better biopsies because we have to do more tests that we used to do. And I think what's important here is clinical information. So the old school phone, it's always useful because sometimes tissue can be wasted because we don't have good enough information. And so we try, we kind of wander in the dark, trying to see what kind of tumor that could be, use a lot of tissue. And then in the end, we get information, oh, he had a prior, I don't know, this or that tumor. So communication, I think it's always important, especially before a biopsy, so we can, be prepared and do only the tests that actually need to be done and spare the tissue for predictive biomarkers. So with that, I would like to thank you for your attention.
Thank you, Dr. Gregor Blaszty. Would you like to introduce the second speaker, Professor Bing Lam?
Well, since he is your previous colleague, right? Maybe
yeah, my friend also, not only colleague. Okay. Okay. If you wish, I can introduce him. Okay, thank you. Dr. Aleix Rosman is a longtime friend and colleague. He will talk on technique or tool when to trust a benign result. I just want to introduce him shortly because he deserves it. He's an associate professor of medicine in Ljubljana University, Faculty of Medicine. He is a 20-year expert in interventional pulmonology and healthcare management. He is the current chair of the ERS, Interventional Pulmonology Group, and he was the director of the Respiratory Endoscopy and Interventional Pulmonology Departments and general director of University Clinic Golnik. And he has published considerably in interventional pulmonology and general pulmonology. Aleix, please, podium is yours, microphone is yours. We are listening to you, and we are seeing your slides. But we cannot hear you, Aleix. I think you are mute. Please open your microphone. Yeah, you're mute.
He's muted, yes. Hello, Sandra.
We cannot hear. Hello. Aleix, open the microphone.
Yeah. Turn on the microphone and I think it's fine.
Yeah, you're still mute, Aleix.
Okay, I think I did now. I'll share my desktop once again. Just a moment, I need a second.
Okay, take your time.
I think it's okay now.
Yes, very good.
Okay, thank you for your patience and too generous introduction. So hello, good evening, good afternoon, and good morning to everybody. So I'll try to speak further the same topic as our pathologist Gregor Blaszty did about when to trust actually to benign result. Malignant diagnosis is in most cases the most reliable, but benign results usually need some additional considering. So technical tool, when to trust to our benign results. So here, I'm sorry, do you still have shared screen? I have some.
Yes, yeah, we see your slides, but maybe it doesn't proceed. Sometimes it happens.
Yeah, I don't see
Maybe
my
just
slides
wait
anymore. Just a moment.
we see your
Okay, now I see it. I'm sorry. Okay, malignant benign. I have to start somewhere. I'll start with a small peripheral lesion, and we start the diagnostic process because it's important to know at least whether the disease is benign or malignant, which impacts a lot how to select the treatment. A lot of patients are comorbid and in some older ages, and we don't want to risk operation in everybody and just to remove the lesion. And I think in the close future, it will also be very important, even if you have a malignancy, what kind of the malignancy is, because more aggressive adenocarcinoma, we most probably have neoadjuvant treatments, even if they are not, even if they're small, they don't have positive lymph nodes, but this is the near future. So all these factors can be controlled by a good diagnosis and trustful diagnosis. So this is a classical diagnostic pathway. So we select an instrument, then a method of navigation, then some method to confirm that we are really there in the lesion. In the end, we take a biopsy with some of these tools, or we select which one we feel is the better. And we have the impression that now comes the diagnosis. But there is one additional step. It's pathology before the diagnosis, as we heard in the previous lecture. And when we include the pathology, when our sample is under trial, the whole picture becomes much more colorful. So pathological outcomes can be very different. So there we can find a specific malignant diagnosis, some suspicious diagnosis or atypia, or even some pre-malignant cells or pre-malignant histology. There might be a specific benign diagnosis, non-specific benign diagnosis, or test can be completely undiagnostic and material useless for further evaluation. So to which diagnosis now we can trust and how to proceed further? Why is this so? So where are the mistakes on our diagnostics pathway? Is just pathologist unexperienced, or is diagnostic, the bronchoscopist unexperienced, or maybe both are very skillful, but sometimes some things happen on diagnostic pathway which we cannot really control. So along our diagnostic pathways, we speak about different gaps. I think there can be divided in three sorts of gaps. First one is navigational gap, the other sampling gap, and in the end, interpretational gap. The navigational gap means that with our tools, we cannot really reach the lesions. So there are different limitations about, for example, bronchoscope angulation, there's no bronchus sign, some CT to body divergence, a lot of things can happen. The sampling gap is the gap where we actually reach the lesion. We confirmed that we are there, so we have a visual yield, but at the end, the sample is not okay. So there's reasons for that. Can be moving lung in very small lesions, insufficient biopsy tools, too small samples, or too little material taken, and so on. And in the third gap, which is interpretation gap, the tissue is adequate. We have a lot of tissue, but result is non-specific, either due to the disease or either we didn't really biopsy the right place, although we were there. And sometimes also atypia. I will talk a little bit this atypic cells a little bit later. So a quick estimation about these gaps. The most preventable, the first gap, navigational gap, has an error margin of 5 to 15%, with most advanced diagnostics methods like Ultrathin scopes, 3D control where our biopsy tools is in robotics and so on. And if we are really skillful and we use the latest technology, maybe we can prevent this gap quite a lot. With classical traditional tools, this navigational gap can be bigger. Most underestimated gap is actually a sampling gap. We are there, but we don't take sample properly or enough, or with proper tool. Maybe we took just a brush instead of cryobiopsy, or we don't use. We try to do with forceps, but forceps doesn't open properly in the tissue because it's narrow there and so on. And the most dangerous gap can be the last gap, which is estimated to 20 to 40%. Which can give us false reassurance if we don't get malignant diagnosis and we underestimate the meaning of non-specific or atypical diagnosis at the end. When we are talking about these gaps, I must quickly say about a few words about diagnostic yield. In the last year, there was a consensus about what diagnostic yield is. And it's very much, it was consensus. And from now on, actually, we must talk when we are using the word diagnostic yield about the strict definition. So this means after we make a diagnosis, we must decide what to do with the patient. So the test is either diagnostic or non-diagnostic. In strict definition, there should be only malignant or specific benign diagnosis. All other diagnoses are negative, or that means they don't go into the calculation of diagnostic yields. In more liberal definition in the past, all non-specific benign atypia or even follow-up was included to boost a little bit the diagnostic yield and promote the new methods for diagnosis, but this is not right. So diagnostic yield means when the bronchoscopy is over, we have to know how to confidently manage the patient, either has a benign disease or malignant disease or specific benign disease. Diagnostic yield is not a disease specific, it's a procedure specific. So all the rest is sensitivity, specificity, and so on are other diagnostic things. So now when we know this, we can go to how confident we are with these different types of diagnosis. It's obvious that if you have a non-diagnostic result, we have to proceed to repeat the procedure because before the test, we didn't know what we have, and after the test, we still don't know what we have because the sample was not properly taken or there was some other mistake, and we still don't know more than before the procedure, and obviously this the last category, here the biopsy shall be repeated. There are two green categories where our diagnosis is very reliable. These are specific malignant diagnoses because false positivity here in pathologists is practically zero. They are confident to tell us that this is a carcinoma or even which kind of carcinoma, which sort, what molecular markers are there and so on. So we can trust the first one. And the other green, which we can also trust, is specific benign diagnosis, either specific benign tumor, which can be diagnosed reliably set, like hamartoma, lipoma, or tuberculosis, or organizing pneumonia, some bacterial, fungal infections, and so on. But other categories like suspicious result, atypia, or some pre-malignant lesions, or non-specific benign result, what to do with this? How dangerous is this? Shall we follow up these patients, or shall we start a secondary procedure or even definitive procedure? Let's see each category separately. First, I'll just mention this atypical adenomatosis hyperplasia. This is a very rare finding in pathology and in bronchoscopy, but I just mention it because usually these are small ground glass opacities, which are random findings in our bronchoscopy samples, or are accompanied with adenocarcinoma. But here, the definition here is that these cells are too atypical to be reactive hyperplasia, but insufficient to diagnose the adenocarcinoma in situ and so on. In some studies, here I cite one meta-analysis of transthoracic CT biopsy, the progression to adenocarcinoma in this type of lesion is very high, but it's also very slow. Nothing here happens immediately, but in the matter of years usually. The next group of diagnoses are suspicious cells. So suspicion cells are so they look suspicious, but pathologists cannot really say that they really are. So we are close, but not there. Maybe there are too little cells in the sample or whatever. And this is a result where the malignancy cannot be firmly confirmed. This is highly suspicious results. And according to the studies which are published, they are not a lot, it is very advisable to repeat the procedure very quickly, not to follow up patients very much, because the majority of these lesions are malignant. And most cancers were diagnosed within the 6 months, and the earlier, the better. So the guidelines here recommend repeat biopsy probably just immediately, or some surgical confirmation if other type of biopsy cannot be performed reliably. So not surveillance or follow-up, but just go for another tissue. Very similar is with atypical cells. So atypical cells show abnormal features, but not enough to make a clear benign versus malignant call. In approximately 25% of these diagnoses can be reactive or reparative changes after infection or tissue injury, for example, after pneumonia or after RDS. But in the majority of the cases, this is also the patient also has a malignant diagnosis, and our sampling was not entirely accurate, not from the right place. And also in this type of diagnosis, it shows out that within 1 to 6 months, about 75% of these patients are diagnosed with malignancy, and prompt repeat tissue biopsy is warranted here. Then the last category are non-specific benign diagnoses like acute or chronic inflammation, or non-specific inflammation, fibrosis, and so on. Here in this big meta-analysis from CT-guided transthoracic biopsies and also from bronchoscopy cohorts, the incidence of malignancy in this group of patients when follow-up is done in repeated sampling, that the the percentage of malignancy is around 20%. So it's high enough, but not so high. So here we can decide according to clinical and radiological parameters, and about this, how reliable we are that we are really in the center of this pathology, what to do with the patients, either to follow up a little or to take immediate chance for another biopsy. So here, both options are viable. So here we can discuss in groups with colleagues what to do with radiologists, pathologists as well. Multidisciplinary diagnostics meetings advisable here to select which patients can be followed up and which patients can must be diagnosed immediately. So here is a summary of these findings. First, we can see if we have a specific benign diagnosis, the false negativity ratio, false negativity percentage is very low, so we can trust to specific benign diagnosis. If we have non-specific benign diagnosis, we cannot trust so much, because in this group can be 20% patients who harbor malignant cells. So rebiopsy or follow-up for at least 1 year, Non-diagnostics, there is no debatable. There should be rebiopsy performed because we don't know what the diagnosis is, and because here is a large percentage of malignant diagnosis in this group. The same with atypia and suspicious cells. Here, rebiopsy as soon as possible is needed, or definitive procedure this is not possible. And in AADH, the progression to adenocarcinoma is reported to be very high, but not very quick. So if I summarize all this, in green, specific malignant diagnosis and specific benign diagnosis can be trusted. All the rest should be rebiopsed, make a rebiopsy, especially if we have suspicious cells or atypia, and if we have a non-diagnostic result. In non-specific benign diagnosis, we shall decide whether to follow up or to rebiopsy the patients following the re-evaluation by radiologists and pathologists to see if the lesion is really suspicious, whether it's big or small or whatever its characteristics are, and also the clinical characteristics of the patients. In AAH, the follow-up is enough because these lesions grow really slowly. They eventually can progress, but not quickly. It takes years for that. Thank you very much for your attention.
Thank you, Dr. Aleix Rosman, for this nice presentation. We can have several questions, I think. We exceeded our time, but we also started late. So we can have several questions. I saw one question in the chat saying, for lung cancer, pathologists at our hospital prefer EBUS cryobiopsy samples to cell blocks obtained with EBUS TBNA for molecular analysis. So comparing cell blocks with EBUS cryobiopsy, I think this question can go to Dr. Gregor. What do you think? What is your experience when you compare cell blocks with EBUS cryobiopsy samples?
Well, in our experience, it's more or less the same. So a good cell block or a good cryobiopsy, it's perfectly the same for us. I think that if we get cytology sample, we will do cell block just, to have a backup, but we'll try to use the first sample, so without further processing for all the molecular biomarkers that we need to do.
Okay, I have a question. We don't use liquid biopsy frequently in Turkey, but sometimes it's required. So with our topic, how can we integrate liquid biopsy in getting adequate molecular and immunologic results? Of course, I think we won't use it frequently, but there will be times that it can help. What is your opinion? I will get opinion of Dr. Aleix Rosman too. Let me hear you first.
So clinically,
no, first Gregor. First Gregor.
I think it's more question for the Gregor than for me.
Yeah, but you can give your opinion too, because yes, Dr. Gregor.
Sorry, I think we have two scenarios where liquid biopsies are very useful. One for primary diagnosis in patients that are not fit enough, to have an invasive procedure, and then at least we can target some EGFR mutations, so they get some TKIs for them. But the most important setting right now is, of course, monitoring of these patients after therapy, because we will have a molecular relapse sooner than a clinical or radiological. So that's important. So this is the two main scenarios where I see the usefulness of liquid biopsy.
And from my viewpoint, for example, if you have a tissue yes, having enough cells, but if you don't use NGS, if you use single analysis, and because of the resections, the obviously valuable tissue, diagnostic tissue or adequate tissue is getting less and less. And in the end, maybe that patient has malignancy, but we cannot decide on the molecular immunologic profile. Can't we use at those times also liquid biopsy? What do you think, Aleix? When the tissue is not enough, pathology uses it for immunochemistry, immunohistochemistry, then for single molecular analysis, they don't, and not every hospital has NGS. And then in the end, there's little tissue left. Maybe in those cases, liquid biopsy can help for molecular analysis and then for treatment, of course.
Well, usually if we have a very small lesions and very scarce material, also the liquid biopsy is quite often negative because there is a little amount of tissue, a little amount of cell-free DNA in the plasma. And so, and also these patients can be radically treated. We can later get a sample if this is needed. So this is quite an open field, quite debatable. And maybe in the next future, when we will start to treat also small aggressive subtypes of adenocarcinoma neoadjuvantly, this will be a bigger issue. But when we have a big tumor and we don't have all the molecular markers, the only solution here is rebiopsy, that we try to take another biopsy. Because from liquid biopsy, we can identify just some biomarkers, not all, for example, not PDLs and so.
Yeah, I meant the second case. I mean, large tumor, but biopsy is not too big, taken from bronchoscopy, and it is gone through several procedures at the pathology department, and there is little tissue left at the end. Maybe that patient cannot be rebiopsied. I mean, not all patients are fit for biopsy or rebiopsy also. Okay, I think it's the answer will come in the future after the studies. Do we have any questions? Dr. Bing, do you have any question for the speakers?
Just one question for Professor Rosman. So regarding assuming a solid nodule and after biopsy, it's non-specific. So how long shall we follow up? Is 12 months long enough to clarify this is really a benign?
It's at least 12 months. It's recommended, but I think I have the feeling that this is case by case decision. If we have a regression of the tumor of this nodule, or it changes characteristics like it starts to dissolve and so on, after 1 year can be sure that we can stop the follow-up. But if nothing particular is going on, or even increases a little bit, or is in patient with high risk of malignancy, we can prolong a little bit this follow-up.
Thank you. Thank you for the excellent talk and the interesting Q&A sessions.
I think I have two small questions for both speakers, and then we can close the session because we exceeded the time. It may be for Dr. Gregor. What are the challenges in obtaining adequate tissue, particularly regarding primary and metastatic tumors? As you know, metastatic tumors may have changed their biology. What you got from primary tumor may have changed in the metastatic tumor. So how do you cope with these challenges? Do you use rebiopsy from the metastasis? Do you use ROSE, NGS, liquid biopsy, or other methods?
Well, I mean, if it's metastatic disease and we get a sample from metastasis, I think we always try to get the sample that it's less invasive for the patient. So sometimes if there are palpable lymph nodes, even we as a pathologist do the fine needle aspiration biopsy, cytology, and if the sample is good, we can do everything from there. So, I mean, it doesn't really matter at that point. We just need one good sample. Usually the driver mutation will be more or less the same in primary and in the metastasis. So all the other maybe mechanisms, additional commutations that are in play are not that important at that time, I think.
Okay. Dr. Alish Rosman, do you have any comment on this?
I will just add that after primary diagnosis and the patient is treated, and when we have a progression, in this secondary event, we try to target the lesion who is progressing, not the easiest available, because at that time, we have to readapt the treatment. And when we attempt secondary diagnosis after initial treatment is failed and we have a progression, then we target the lesion who progresses most.
Yeah,
Okay.
that's true.
There is a question now coming. It says, Dr. Gregor said molecular replace happened before clinical replace. Can you explain that more? Are you using this clinically in any way?
I just think that by liquid biopsy, we see the mutation coming up again before there is any radiological evidence of progression. So at the time, our oncologists can, of course, react sooner. Yeah.
Mm-hmm. I have to confirm that we are just preparing a publication on that at the moment. One of my PhD students is doing that. That it shows that progression can be detected at least months or two before we have radiologically visible progression.
Okay, yeah. I think I will ask the last question. And the communication between the pathologist and the interventional pulmonologist is very important. Its role is very important, critical, but the communication, should it be before the procedure, after the procedure, or both? I mean, I always talk with my pathologists in the hospital, either go to their room or call them before, because some things maybe we don't know the details in pathology as pulmonologists. So what do you think? This question is to both of you. Before, after, or both? The communication between the pathologist and interventional pulmonologist.
I think that all the time. Before the procedure, from the viewpoint of interventional pulmonologists, before the procedure, we have to communicate whether we expect a primary tumor or metastasis from some other location if patient had some tumor like breast or melanoma or whatever in the past years. So this directs the pathologist very much. Then during the procedure, when we want to have to know what the result of rapid on-site evaluation are, and at the end of the procedure, when the result is non-diagnostic, we ask what the hell went wrong? Does it make sense to repeat the biopsy, or repeated biopsy won't tell us much? So shall we just go for something, for example, especially in lymphoma? We suspect something, we get a nice cryobiopsy sample, and we have something, but not definitive. And then we ask pathologists, does it make sense to repeat the cryobiopsy, or the whole lymph node shall go out? So that's also an important part.
Yeah. Can I get a brief comment on that, Dr. Gregor?
Yeah, I agree. Different times in communication have different goals, of course.
I think it should be before and after.
Yeah, of course.
Before is much more important than you know what you do. Yeah. I think we exceeded our time a bit more than enough. So we have to finish. I thank the speakers, my co-chair, Dr. Bing Lam. It was a nice, constructive, very teaching session for me too. So I thank the audience too, and we are closing our session. Thank you very much. Have a good day, good night. I don't know, you're in Europe is good night, but in Asia, it may be much later time, midnight or something. Yeah. Bye-bye. Thank you very much.
Thank you. Bye.
Thank you all. This concludes session 4 of the webinar. We've had 4 jam-packed sessions. And last but not least, I would like to introduce the last session per se, roundtable panel discussion with moderator Professor Levant Delar, titled Balancing Rapid Technological Advancement, Reasonability, and Pragmatism, who can still keep up.
Thank you very much, Michael. First of all, I want to thank WABIP for this outstanding event. It's really miracles. And another thank to the audience for still being with us. We will discuss about the new technological advancement together. We have 6 very precious discussants. Dr. Stefano Gasparini from Italy, Dr. Atul Mehta from USA, Dr. Katerina Antoniou from Crete, Greece, Dr. Tuichi Yan from Taiwan, Dr. Lamia Sharif Moran from Morocco, and Dr. Ravi Mehta from India. They are all from different parts of the world, and their access to new technology is very different from each other. So, you know, the interventional pulmonology is advancing at an unprecedented pace nowadays. Robotics, navigational systems, new therapeutic approaches are changing our practice. But we have to decide how much is too much. So, do all patients benefit from the newest tools, and how should we decide which innovations to adopt responsibly? That's our question for today. Our panel brings together very precious discussant in front of you. And so I have 3 basic questions to all discussants before I start. What proportion of patients in your daily practice truly benefits from the newest technologies? This is the one. This is the first question. And the another one, how do you evaluate whether a new device or technique is worth integrating to your daily routine practice? This is the second question. And the third one, when do you choose advanced technologies over standard procedures? We will start with Dr. Gasparini, and I will give the word to Professor Gasparini. Please, Stefano.
Yes, thank you very much, Levent. Again, my congratulations for this wonderful webinar. So the title of this roundtable and your question are a little bit difficult. Balancing rapid technological advancement, reasonability, and pragmatism. Who can still keep up? Well, I will try in 3 minutes to discuss a little bit and to focus on some point of discussion. In recent years, a lot of innovation have been introduced in bronchoscopy, and the pace of progress is astonishing and unprecedented. Every month, it feels like there is a new device, a new platform, a new algorithm being introduced in bronchoscopy. The first question is, how many of these actually change the way we practice bronchoscopy? and how many are destined for oblivion in storage rooms. Some example, in recent years, the advent of echobronchoscopy has changed and improved the way we perform bronchoscopy, while systems such electromagnetic navigation bronchoscopy, despite the extraordinary initially premises, have ended up in warehouses in many centers and are no longer used. The question is, does this new technology truly improve patient outcome, or does just improve the marketing brochure? To answer this question, a fundamental element is needed that interventional pulmonology lacks. That is, well-designed, controlled, prospective randomized study that provide evidence of a real advantage of one technology over another in terms of efficacy, outcome, safety, and costs. Together with Alex Rothman, we wrote an editorial on respiration some time ago entitled Dancing in the Dark, in which we underlined how, while for the introduction of a drug on the market, many prospective studies are necessary. For bronchoscopy devices, one study with few cases in a center of excellence is enough, and the device is on the market. Talking with some colleagues about this problem, I was told that it is difficult to carry out randomized prospective study because they take time, and in meantime, new technologies arise, and when the study ends, it becomes outdated. But this is not true. As demonstrated by the recent, beautiful, prospective randomized study published by Lenz et al. And co-worker in the New England Journal of Medicine, comparing the transbronchial versus the percutaneous approach for peripheral nodules, demonstrating that the transbronchial approach is not inferior in the diagnostic yield to the percutaneous one, but involves a lower incidence of complications. In this study, however, the transbronchial approach was performed with a robotic bronchoscopy platform with tomosynthesis, digital fluoroscopy, radial EBUS, and in some cases with combined CT. Can we achieve the same result with less expensive system? For example, with ultrathin bronchoscope in place of robotic bronchoscopy, maybe using cryobiopsy. We don't know. I don't have the answer because there are no prospective randomized studies comparing large case series. We need evidence, not only enthusiasm. And the last question, who can still keep up? Keeping up doesn't mean buying every new device. It means staying informed, being open to innovation, and knowing when and when not to adopt the technology. It means asking, does this new technology truly improve patient outcome, or it just improve the marketing? Not every innovation needs to be embraced immediately. Should we all try to keep up with every new step forward, or should we decide carefully which steps are actually worth taking? Obviously, keeping in mind the economic resources at our disposal. And the circle closes. To achieve this, we need evidence from controlled study. This is my message to all the people that are participating and in the audience of this round table. We need evidence in interventional pulmonology. Before accepting new technology, new expensive technology, we must be sure by randomized, controlled prospective study that this new technology real improve our way to perform bronchoscopy and really and that it really give benefit to our patients. I've finished, Levent. Thank you.
Thank you very much, Stefano. It was very brief and condensated comment. I think the Atul is not here, huh? But Ali Musani is here. I can give the micro to Ali. Can you share something with us, Ali?
Microphone, Ali.
It's not mute, I guess. Yeah. We cannot hear you. No sound. Okay. We can pass you for now. Okay. Please, Dr. Katerina Antonio. Can you give your comments on that?
Yes. First of all, thank you so much for the kind invitation. It's an honor to participate in WABIP International Webinar and to share this roundtable with excellent colleagues and friends. From my point of view, of course, I agree with Professor Stefano Gasparini about the educational procedures that we have to do, not only to buy a new instrument, but to give the opportunity to people to learn about this before to buy this. And of course, we have to be informed, even if we do interventional pulmonologists, even if we don't do for our clinics. And the other issue, which is very, very important, I think that we have to do a multidisciplinary discussion and to use the tools, all available tools that we have in every setting, and each of us is working in a different part of the world with different expertise in different instruments that we use for the best of our patient. So at the end of the day, if we go also back to the previous discussion, I would use the new tools, the interventional pulmonology, not only before, so to have a discussion with pathologists, with radiologists, with maybe some AI tools, with the clinical history of the patients, with the previous history of the patient, not only, of course, in malignant, but also in non-malignant diseases, such as the very good example that our colleague gave us before. So before, during the procedure, after, when we have to conclude about the diagnosis, where I also think that the pulmonologist is a central person to coordinate all this democratic discussion between experts. But I would go also a little bit further. I think that also in the follow-up, because in non-malignant diseases such as the interstitial lung disease, but also in malignant diseases, we have progression of the disease. So I think that novel tools, a little bit less invasive, if possible, such as liquid biopsy, or let's say not so much interventional in order to have some adverse events for the patient or to exacerbate the disease, would be also more patient-friendly for the follow-up of the initial diagnosis, which a lot of time is a moving diagnosis. And then I will conclude, because I come to the field of ILD, where actually with Venerno Poletti as members of the ERS ATS guideline for the diagnosis of IPF and other interstitial lung diseases, we introduced as European community the cryobiopsy there in the diagnostic algorithm of IPF in in addition with BAL, which is a less invasive technique, but still very, very important for the cytological part of you. So actually, we convinced the American colleagues who did have the expertise about cryobiopsy and BAL. So I think that sometimes we need to discuss with other colleagues, of course, according to the evidence, because there were a lot of expert randomized trials published in the cryobiopsy field in ILDs. So in combination with BAL, we have introduced this methodology in the guideline, an international guideline, which is endorsed not only by ERS ATS, but of course Japanese Society and ALAT. So I think that this guideline gave a lot of importance to the interventional pathology and integrated that in our diagnostic algorithm. So I think this is important for the patients all over the world because we have new treatments available. So it is important to have the diagnosis early in order to have also the prognostic and therapeutic evaluation of the patients. And also I would like to share one comment that as I also believe that progression is very important in malignant and non-malignant disease, what we would like to further introduce in our thinking is beyond of the multidisciplinary and also with other specialties. We do that pathologists, radiologists, rheumatologists. Also, we try to find less invasive tools in order to have a better follow-up for the patient. And as you know, malignant and non-malignant diseases are very close. For example, 10 to 15% of pulmonary fibrosis patients are developing lung cancer. So actually, we have chronic respiratory diseases. So often we have to screen the patient for in order to update the diagnosis and the therapeutic management with antifibrotics. We come as ILD physicians in front of a cancer of a nodule. So we have to work together. Now we develop more task forces through the European respiratory societies to integrate how we have to manage lung cancer in the field of IPF, but also how we have to address the complications with new like immunotherapy with in those settings of patients. So I think that interventional pulmonology with novel tools, less invasive tools, available tools all over the world is very, very important to the hands of pulmonologists. I think we do great in this approach. And I think that new classifications, now in few days, we will listen about the new IIP's classifications that we have introduced the concept of BIP, which means also the bronchiolytic involvement in interstitial lung diseases and the alveolar filling diseases. So I think that starting from this classification, we are going to go back to cryobiopsy because in the past we used VATS or other techniques to integrate cryobiopsy and BAL to the new classification. So I think it is a very nice trip from back to the future and from the future to the back. So I think that novel classifications better provide more information coming from tissue and from morphology. So I think that interventional pulmonology, with the right clinical reasoning and multidisciplinary integration, gave us and will continue to give us a lot of information and will become in the future, I think, more patients-friendly. Thank you so much.
Thank you very much, Katerina. It was very helpful talk. Lamia, the micro is yours.
Yeah. Hello. Thank you, Levens. Hi, everyone. And many thanks to the WABIP for the invitation. And it's really a true honor to be here today with such inspiring mentors and outstanding experts. So when I look at the rapid pace of innovation in interventional pulmonology, like robotics, navigation systems, or valve, emphysema treatments, I'm filled with admiration, but also with this question that resonates deeply with me. Who can still keep up? And I ask this question not only as a pulmonologist, but as a physician working in a low-resource country. In my daily practice, the contrast is striking. And while the world speaks about robotics, compensity, or 3D stents, sometimes my team struggles to secure the basics, like to have regular access to EBUS or to obtain the essential disposable tools as cryoprobes or APC probes or even EBUS needles. And when I see the exorbitant costs of robots, EA machine, the gap feels even greater. And in our countries, we learn that every tool and every procedure must prove its worth, not only clinically, but also economically and logistically. It's a constant test of relevance. Is a new technology viable if it requires complex maintenance or impossible to find consumables? Can it truly transform lives if its cost makes it inaccessible to the vast majority of patients? And this reality has shaped my perspective. It has taught me that technology alone is not progress. Progress is when innovation meets reason, when evidence guides enthusiasm, and when pragmatism ensures that a technique can truly reach the patient who needs it most. And here we often learn to achieve good results with limited resources. But this is not a reason to ignore what is happening elsewhere. On the contrary, it makes it even more important to stay informed, to keep training in the best centers abroad, to stay open and ready for change, and to push our health leaders to always place improvement and the quality of care at the top of their priorities. Because keeping up is not only about having the latest device. It is about staying curious, staying critical, and staying connected. It is about embracing the global community of interventional pulmonology, where knowledge crosses borders and collaboration allows us to rise together. And today, this webinar is the best example. So yes, I may not always have the most advanced machines, but I do have patients whose lives are transformed by the procedures we can offer. I do have colleagues and mentors worldwide who share their knowledge generously. And they do have the conviction that innovation should not be a privilege of geography or economy, but a right for every patient everywhere. So who can still keep up? I think we all can. If we balance speed with good judgment, if we combine technology with humanity, and if we ensure that no voice and no country is left behind. And thank you so much for your attention.
Thank you very much, Lamia. It was very, very touching. And Dr. Ravi Mehta, could you please share your thoughts with us?
Sure. So coming at the end, I think it's always easier because a lot of the lovely stuff has already been said. I think just a few general comments before I come to your three specific questions. One is that I think, as was mentioned before by Dr. Gasparini and Lamia, few fields have seen such an explosion in technology of an impactful nature in what was otherwise known as the medical field, pulmonology, to make a difference in care. And I think parallelly, we saw the explosion in oncology, and between the two, I think there's been a huge impact, and that's why this juggernaut of intervention pulmonology and such discussions. The second sobering statement is what Stefano said is that actually some technologies have just been stepping stones to the ultimate useful tool. And we have seen, they come, they go. So the famous statement, Veni, Vedi, Visi has been, I came, I saw, I conquered, is I came, I saw, and I just got relegated to the background. So I think that has been very important, but they go through their cycle of projection, papers, tons of discussions, plenty of meetings, loads of webinars, and ultimately go into the closet and replaced by something else. And very rarely do we do an audit of how we did this, what we could have done differently, and whether industry was making us dance to the tunes or we actually had something useful. You're reminded of the iPhone analogy. 3 was just a stepping stone to 5, which was the ultimate one. So coming back to the main questions, I think a lot of it is country specific, also region specific, and now having 1.5 billion people and overtaking every country of the world with the highest population, we really have to be very cognizant of what the role is in your own setup. Partly reflected by Lamia also when she mentioned that. So to answer the question of which percentage of patients benefit from new technology, it comes down to what indication. And the two new buzzwords have been nodules and valves. Interestingly, largest country in the world, very few tools for nodules and no valves. It just doesn't make sense. And like I said, since it's guided by industry, both of these tools, robotics, we are, I think, far away from, at the most, we'll have a radial EBUS and few tools of navigation, but we have nothing more. So we are a country of nodules and pleural effusions, tons of tuberculosis, infections, inflammatory processes, neoplasms at an all-time high. But to actually say that we have so many nodules so as to try and get these new technologies is a very big statement. In fact, in such our setups, looking at practicality, pretest probability, the impact of the procedure, the complications, CT-guided biopsy still, despite all the literature lambasting it, still scores. And let's not forget, they are also in their own webinars and meetings are enhancing their skills. So that's one thing. In terms of valves and lung volume reduction, unfortunately, again, we don't have much of it at all. We just have intervapor right now. And so for us, interestingly, triple therapy and rehabilitation are probably still more useful tools for COPD patients rather than thinking of aggressive intervention pulmonary tools. Having said that, we have tons of central airway obstruction, pleural effusions galore. Probably we have more pleural work than most parts of the West. And that's why there is where we have a differentiation, and conventional technologies of West, well-established nature such as EBUS and fluoroscopy, in fact, stay as a mainstay of what can be done. How does one evaluate? I think those are the classical tools. It has to be relevant. Of course, the studies have to be there, as Dr. Gasparini said. You have to extrapolate the studies to your setup. Your patient population should both qualify and be benefited by that. And lastly, in the panorama of their care, your procedure should make sense. It's not about us only. It's about the fact that the procedure, with all its safety, the integration, the economics was actually fell in the appropriate panorama of care. And this is especially true for oncology. Benign disease, of course, is a much easier substrate to deal with. Then the question was advanced tech over standard procedures. Well, obviously, if the stakes are high, or if the lesion is difficult or the pathology is difficult to reach by standard procedures, or sometimes one has to candidly admit that the skills of the operator are not commensurate to the challenges of the lesion, is when advanced procedures come in. And that's when technology is used. Unfortunately, the biased mind will often take the advanced technology and move it leftwards and make it routine procedure. And we saw this struggle in TBNA versus EBUS, and Atul is not there in this discussion. He will still stand on every forum and say that we do too much of EBUS for large lymph nodes also. So no right or wrong. There's a continuum over there, many shades of gray, which actually justify that. So to conclude, I think it's basically over time, after 2-3 decades of doing this, you look at every technology not only as an exciting tool to be implemented aggressively, but a judicious tool to be evaluated appropriately and used in the context of both literature, disease, indication, safety, and your own setup. Thank you.
Thank you very much, Ravi. It was perfect talk. Ali, can you talk? No, he can't hear you.
He's not a panelist, he said, so he's not been given
Yeah,
privileges.
you're right. Yeah, that's why. But I asked to Michael, he can do something, but no. So, dear participants, we are waiting for your questions. We are waiting for your participation, as you named it. And I have a question for the participants. How do you decide to their own to your hospitals whether to adopt a new device? Could you please share your answers with us? Okay. And another question to all you discussants. Where do we draw the line between the rational patient focused use and excessive technology adopted? Can I have your answers? Stefano? Where is the draw between, where is the line between the rational use and the excessive use?
Between the
rational use, patient-centered, patient-oriented use, and the excessive use, the advanced technology, I mean.
You know, one of the major problem, as I told you before, is that you should be convinced by evidence that the new tool really is useful for the patient. At that point, for instance, we have a lot of studies that demonstrate that robotic bronchoscopy may have a sensitivity of 80–84%, but sometimes they are with combine CT. They are used with combine CT. To prepare this discussion, I look at the literature. We don't know exactly how is the merit of robotic or how is the merit of combine CT. There are some information, but we don't know, for instance, if an ultrathin bronchoscope, as we have seen this morning, interesting cases that with ultrathin bronchoscope and fluoroscopy, the diagnosis of very small nodule was done. We don't know if we use ultrathin bronchoscopy and combine CT, we can have in the same in a random study, we can have the same results as using robot and combine. Because if we compare different studies done by different teams at different institutions, the variable that may impact the sensitivity are a lot. The bronchus sign, the location, the experience of the operator, the time taken, the rows or not rows, the sampling instrument used, some biopsy, needle, cryo, brush. So there are a lot of confusing factors that may, in any case, with this fact well in mind, I think that the major limiting factor that avoid the use of a new instrumentation is the economical factor.
Exactly.
We have demonstrated that the transbronchial approach is not inferior in the New England Journal of Medicine of June, so just 3 months ago, is not inferior to percutaneous approach. But what about the economical comparison? Yes, we have less pneumothorax, but this is well known for a long time that the transbronchial approach, for the transbronchial approach, the risk of pneumothorax is less than the risk of pneumothorax with percutaneous approach. But what is the cost? A needle for a percutaneous CT guidance costs 50 euros, maybe. What is the cost of a robotic approach with ultrasound, with tomosynthesis, and maybe with the use of cryo? What is the cost? It's 1,000 euros or dollars, as you want. So the economical impact, influence, the choice, I think for the majority of colleagues in the world, probably everybody would be very happy to play and to use the robotic bronchoscopy. What we should do is first demonstrate the real advantage of robotic bronchoscopy over traditional system, together with the same guidance system, because we cannot compare robotic and combined CT versus ultrathin and fluoroscopy. We must compare the same guidance system. But I'm sure that robotic bronchoscopy probably will demonstrate its value. At that point, I cannot choose robotic bronchoscopy if my hospital doesn't allow me to spend 2,000, 3,000 euro to diagnose a nodule, when the interventional radiology do the same with 50 or 100 euro. This is the major limit of our specialty. So I repeat, for the choice, first, more evidence that our approach is more convenient in terms of safety. And second things, try to convince the companies to reduce the cost of this new technology. And probably it will happen if the diffusion of this technology will widespread and will increase further. But at this moment, the economical barrier is the major limitation factor.
Thank you, Stefano. Katerina?
Yes, I fully agree with Stefano about this. The economic issue is very important, but and of course the safety. However, I think that even in ideal settings, for example, let's say for Italy, they do very good cryobiopsies. We take in consideration for interstitial lung disease. For example, we take the expertise also in the guideline. For example, we say that the cryobiopsy could be a tool in the setting and not all over the world, because not all the centers have availability of this technique. The same is for other tools that we didn't, for example, put them in the guidelines, such as the genetic molecular test, which is less available, and we have less studies and less evidence, as Professor Gasparini stressed, about the diagnosis of malignant and non-malignant diseases. Moreover, I think it is very important in an ideal setting, even if you have everything in front of you and you don't care about the money that you have to spend, which is not an ideal. It's, we can't live in this situation anymore. I think before to choose the diagnostic approach of the patient, for your patient, of course, you take in consideration the patient, the particular individual, you have in front of you the clinical history, which is very, very important, and to choose the tools you want, not only for the diagnosis, but also to have a prognostic and therapeutic importance for the patient. For example, you are not, if you don't have the cryobiopsy and you have a patient of 75-year-old with a probable UIP pattern, with some autoimmunity, flavor of autoimmunity, maybe it is not so important, if you don't have the cryo to, for example, for me, to ask to be done in Athens, for example, but to take in consideration the CT pattern, the clinical evaluation, and the multidisciplinary discussions with rheumatologists, the BAL, etc. So I think that in every setting, even if we have the possibility to spend millions of dollars, the safety of the patient, but also to give him not only the diagnosis, but also the prognostic and therapeutic implications of, especially if we have to spend money or we have to do an interventional pulmonology procedure with the risk of balance, between balance and risk. So I think those are factors that we have to take in consideration, even in an ideal setting. And of course, to further work in the research, not only with studies to compare the techniques, but also to provide, especially for the follow-up, but also for the screening, less invasive techniques, low dosity, lung ultrasound for the follow-up, for example, breath analysis, AI tools, etc., to integrate with all the available tools we have.
Thank you very much, Katerina. Before Lamia and Ravi, there are some comments from audience, which are very precious. From Dr. Jacqueline Kagima from Kenya, says, how can we leverage training in low or middle incomes locally without traversing geography? The costs are travel, separation from family, etc. is a huge burden to those of us in low-income countries, and yet we want the skills, and more importantly, our patients need the services. So the teaching, the learning process is the other part of this topic. Lamia, could you say something about this?
Sorry, so it's about the cost of the training.
Learning,
exactly.
How can we learn the new technologies, especially in low or middle income countries?
Yeah, the problem is in our countries, we don't have expert center to learn. So, and it's interventional pulmonology is not something theoretical. We cannot learn, for example, with webinars, or it's a very good thing to have, of course, distance learning. But at the end, we must go to expert center to know, to have the real good techniques. And of course, we cannot just go to any center in the world. We must choose the good place, because we need to come back to the country with something really good, the very good techniques. So, for example, I thank the WABIP for the opportunity they give to our countries with in Turkey, in Turkish with you for the training. And also we can do it, for example, with our hospitals. We can just explain that we can go for 1 month or 3 months training in another country, but when we will come back, we will come back with something new, and it's for our patients. So maybe we can negotiate this with the hospital, and I believe it's not always easy, and of course it costs a lot. So I don't think that I have the perfect answer for these questions, but at the end, it's
That's perfect.
yeah, it's personal, very personal, effort and
Personal and universal. Yeah, personal and universal. There are any other comments? From Jane Afri Mensah from Ghana. She is a graduated fellow of the IPR. I agree with Professor Stefano. The economics is a great factor. In my situation, I will choose Ultrathin with fluoroscopy. Robotics is far inside of for Africa. Yeah, Jane is totally right. And another point, Diana Warangu from Kenya, who is selected fellow for IPI. Great point on cost. Do you think cost effectiveness analyses are necessary? The question goes to Stefano. Second point on convincing companies to reduce cost. Do you have some creative ideas how to go about this, Stefano?
Companies, the main goal for companies is to make money. So it's very difficult to convince them to do the contrary. The only way we can have is to hope that the diffusion and the increase of number of tools around the world may reduce the cost. But in any case, I think that the major income for the company came from disposable material. Is not the major income from the company, the cost of the robot probably. You pay the robot once and then you have the robot, but the problem is the disposable material that you have to use for each procedure. And this is one of the major way why the company increase their income. I think that the only thing is to increase the number of machine around the world so they can reduce the cost when they sell more and more disposable tools. Is the only way. Otherwise, no. It's just a dream. It's just a dream to ask to the company to reduce the cost.
You're right, Stefan. I totally agree. Ravi, I have another question for you. Ali Musani says, asked, should the robot be used in India or and other developing countries? What do you think?
No, I totally agree, and I replied back to Dr. Musani's statement over there. I think and then you've got a nice trail over there where Professor Takahiro is also mentioning that we need to exhaust conventional strategies before we jump onto the newer ones. And I don't think there's going to be a right answer to this. History is repeating itself. When we went in from one technology, as I said, conventional TBNA to EBUS was a jump, and EBUS has really made a big difference, but there was a huge transition out there. The nodule to robotic story is very similar, and we will not have an answer for a while. But to play the purist, the wise person, and to actually have, as Professor Gasparini says, dissemination, you need to take a procedure which is easier on technology, cost, and applicability to actually have widespread dissemination. And for that, it will be bronchial mapping, whether it's ultrathin with the fluoro, or it's going to be the radial EBUS, which has still made a lot of inroads. I think that would be the way, and then leaving the actually very complex ones, or high-stake ones, to robotics. Unfortunately, the commonality of the advanced technology shifts it leftward, and it becomes standard of care, and that's something which often comes from the Western world and has limited percolation in our part of the world. And now sitting with, like I said, 1.5 billion, we have nodules galore, and we have so many benign nodules that it's very difficult to justify an extremely expensive robo. And so the robo company is also smart. To paraphrase Professor Gasparini, they're not coming into India. They know that it's not going to penetrate. They know that the regulatory part to get it over here, the learning curve and the implementation will be so challenging that it's probably not worth any economic sense for them to get in, as against us to even economically justify it to our patients. So it's a complex thing between the role of the technology, the application of the technology appropriately, how practitioners take it, how industry takes it, and ultimately I think the conventional tools will still be the old guard and the holy gold standard.
Thank you very much.
However, if I can add an example of reduction of cost, now the combi in CT reduced the cost in comparison to 10 years ago. I remember that when I asked to my hospital for the first combi in CT, maybe 7-8 years ago, the cost was really impressive, and now there are different instruments that are smaller and dedicated to the bronchoscopic or endoscopic suite that are more cheaper in comparison to the previous one. So probably in the future, with the dissemination of the technology, I hope that there is the possibility to have a reduction in cost. At this point, the transbronchial approach could be really competitive in comparison to interventional radiology percutaneous approach.
Thank you, Stefano. So I have one last question for all of you. How can we collect the true evidence altogether? How can we collect? What is the best way? What is the best way to collect good evidence, good scientifically good evidence? I mean, do you have any idea? Ravi, Katerina, Lamia.
I think you've asked the most difficult question in the end.
Yes.
Because if you take the variables, for good evidence, you require a standard product, standard technology, standard indication, standard operator. We take the wheat away from the chaff, and that is so difficult. It is so extremely challenging, and I don't think there's a right answer. It's just as complex as the learning question, which our African colleague brought about. But I think that somewhere in learning, AI will make a difference. You know, we have held on to these conferences and all because, let's face it, even these conferences make money. And that's why before COVID, we used to never have these virtual meets. But at the end of the day, I think learning can be made much simpler by introducing new tools. So that's the learning point. But in terms of collecting evidence, dauntingly challenging. I think maybe global consortiums are required now with the people sitting on the top who are really good at research to try and separate the wheat from the chaff and give reality discussions from controversies and leave the rest to the learner.
Any other comment? Lamia, Katerina? No? Thank you. Yes?
No,
Please, Lamia.
Yeah, I thank you so much for all these very important ideas. And I have, for example, there is some countries where IP is in the beginning. So maybe if, for example, we build some center of experience, the expert centers in each countries and we can invite in these centers some international experts like you, like Professor Gasparini, Professor Musani, and maybe the European and the American centers can put pressure on the companies to give some different prices for these centers, because they will be the center of expertise in these countries. So like that, we can work more. We will have data, we will have our registers, and we can also see what really works for us and what not work is working for us. Because for example, when we are doing just 5 or 6 EBUS on the month, you never can know if you are doing well or not, even if you are at 100% positive diagnostic. You don't have enough cases to judge your work.
Thank you, Lamia. So, any closing remarks? We have to exceed our time. Exceeded our time. Any other closing remarks? So, thank you very much. So, we will deal with inequality. We will deal with learning curve and learning for middle and low income countries. We have to plan teaching plan for them, and we have to exceed inequality somehow. I don't know yet, but sharing the thoughts together, it's very important step, and WABIP provided this to do that. Thank you very much for all discussants, and see you again.
Work together.
Thank you.
Thank you. Bye.
Work
Thank you very much.
together.
Bye, everybody.
Bye.
Bye.
Thank
Bye.
you, everybody.
Take
Bye.
care.
Thank you, Michael.
Thank you all.
Bye,
Thank you,
Micah.
Thank you,
Stefano. Thank
Michael.
Great
you,
job, Michael.
Devon.
Great job.
Indeed.
Thank you very much.
This marks the end
Yeah,
of
but-
the panel discussion and
Indeed.
the
Michael
WABIP
has the
webinar day
rest.
1 program with 25 chairs and presenters and 400 unique attendees. So
How many attendees?
400 unique attendees.
Wow. Very well done.
Quite high for this hour.
Keep in touch also, keep it up also for Sunday, yeah?
Yeah.
Yes. So
Yes,
tomorrow
of
is day
course.
2, and I look
Okay.
forward to seeing you tomorrow, day 2 of the program.
What time is the tomorrow morning? What time?
The same time. The starting time is the same.
Okay.
Thank you, Professor Saka,
Thank
for
you.
organizing that and WABIP. Work together all over
Bye-bye.
the world. Bye.
Bye-bye, all participants.
Tomorrow.
Thank you very much.
Bye-bye.
Thank you
See you
all.
tomorrow.
I enjoyed very much in today's program.
Thank
Thank
you.
you.
See you tomorrow.
See you tomorrow. Thank you.